woman said, water has broke and I'm going to the hospital. And thank you so much for empowering me on this knowledge on how when to go to hospital. I was not aware. So there are a lot to be done from our side. If we could, just start telecounseling services for the pregnant women in the rural areas, because now most of them have phone. There were hardly 10 women out of 200 women who did not have phones. So easily we could give the teleconsulting services, which is very, very essential for our women. And partner involvement. So one of the studies was my student is doing is on partner involvement in postnatal care. We could also have studies on partner involvement in antenatal care, decision making, etc. And also deployment of skilled caregivers at peripheral level. The WHO as well as evidence in the world has shown that the nurses and the midwives who are trained and skilled can give competent quality antenatal services, which is the future of midwifery services in our country, which could save lots of women, and very soon we can achieve the millennium development goal. So these are the antenatal advices you can read. The most important thing I would like to emphasize again is the substance abuse at all visits has to be asked. And also, there are a lot of queries on the coitus. Can we have sexual intercourse? So many of the women, they abstain from sexual intercourse thinking that it would harm the baby. But sexual intercourse or coitus is quite safe during pregnancy until and unless it is complicated. Hence, this myth has to be dispelled among the pregnant women. And follow-up services, over the counter drugs are very harmful, and these are the things which has to be told to the pregnant women. So I would just summarize with the WHO recommendation for the antenatal care. That is, previously it was four, minimum of four contacts, but now the recent evidence says, or WHO recommendation says, a minimum of 8 contacts are recommended to reduce perinatal mortality. Counseling is very, very essential, especially on the nutrition and also physical activity. Minimum of 30 minutes of physical activity is, at least a brisk walking is advocated during pregnancy. And daily iron and folic acid supplements with the elemental iron as well as the calcium is required to prevent anemia, PIH, puerperal sepsis, preterm birth. You can just read on the WHO recommendation in women with HP11 or above need not take on daily basis. They can have alternate days. In anemic women, they have to take daily basis. BD or TID 6 milligram as per the recommendation on the health status. And once the HP level increases to 11, they can be enough. So please go through the guidelines. And tetanus toxoid is recommended for all pregnant women. 2 doses, 6 weeks apart, you all know that. And then at least one ultrasound scan before 24 weeks of gestation to estimate gestational age, fetal anomalies, multiple pregnancy, and reduce the medical intervention or preterm induction of the pregnancy, and also induction of labor for post-term pregnancy, and improve overall pregnant woman's experience. And once again, let me reiterate, the substance abuse is under the carpet phenomenon. Hence, it has to be emphasized that substance abuse, whether it is alcohol or tobacco, smoke form, smokeless form, even if it is a homemade wine, has to be totally no in pregnancy. So with this, I end my talk. I once again thank the organizers and the moderator for this session. Thank you once again, and also the audience for the patient listening for some of my references. Thank you.
So thank you, Dr. Smita. It was a wonderful presentation. Although you had only 30 minutes, I was also wondering like how will you finish this vast topic with just 30 minutes? And you summarize in a very beautiful way, which is relevant to the topic. Plus, you had emphasized on the substance abuse, which is not very commonly told in many of the antenatal care sessions. And also important thing is that psychological aspects, especially domestic violence, with evidence-based learning, evidence-based information about like 71 percentage of the mothers have been under domestic violence, and it is very much it is a thought-provoking situation. Like, what should, as a midwife, what should I do for this situation? So it was something very informative, and especially the controlling behavior of the in-laws, husband, and other relatives. All that is put it in a very nutshell for and very crispy way you had given us to eat, and it is our attitude and aptitude which should be able to absorb in it and said, please, you can ask now. I give you 2 minutes time.
Thank you so much, sister, for the feedback.
Any participants like to ask any questions? So, or I should I go for the next person, Dr. Venkatalakshmi, or should I wait for you?
Yes, ma'am, you can carry on.
Okay, thank you. And now I like to present before you the second resource of the panel member of today, Dr. Venkatalakshmi. She is in charge of OBG. She's a lecturer in the National Institute of Nursing Education, JIPMA, Chandigarh. And also, she has done her BSc from College of Nursing, Bishop College of Nursing, and MSc from Apollo College of Nursing, University. She got like for 19 years of experience both in teaching and bedside, and she has got lot of publication at her credit journals as well as in the chapters in books. And she has also attended maybe conferences. She has participated, presented, and she is a resource person at various national and international conferences, and also is examiner in various centers like in Jipma Chand University, AIMS Jodhpur, Kishka, and many other universities like Punjab University. And he is also a life member of TNI, SOMI, and also very specially Chandigarh chapter. She is also a joint secretary. And ma'am, you will be dealing with the early detection and treatment and referral for complications during antenatal care. Welcome you, ma'am, and your time is for 30 minutes. And as everybody is adjusted with the time schedule, I know you will be also doing the same. Thank you. Welcome.
Thank you so much, madam, for your kind words. I'm from PGIMR Chandigarh. Jitmar is in Pondicherry. So, with your kind words, I would like to start my session. Please allow me to share my slides. Yeah. So within half an hour, I am targeted to finish my talk on early detection and treatment or referral of complications during antenatal.
Sorry to interrupt, ma'am. Ma'am, your
Am I
voice is,
audible?
yes, ma'am, you're audible, but voice is low.
Very feasible.
Hello? Hello?
Yeah, can you raise your voice, Venkatalakshmi, ma'am?
Yes, ma'am. Now is it
Ah,
audible?
now it is, yeah, now it is audible.
Okay, my video may not be visible then. I'll be just
No, no,
speaking.
we can see.
Okay, fine. So just now we seen about the antenatal care, which we talked about the normal pregnancy. So here we are going to discuss about the abnormal pregnancy, or we'll call it as a high risk pregnancy. So pregnancy is considered a unique physiological normal episode in a woman's life. All pregnancies and deliveries are potentially at risk, we can say. So but some of the pre-existing diseases or unexpected illness of the mother or fetus can complicate the pregnancy even. So what is risk? Risk is a reflection of the incidence of an adverse health outcome arising in a defined population during a given period. So about 20 to 30% of pregnancies belong to the high risk category, and they are responsible for 70 to 80% of the perinatal mortality and morbidity. So we have to desire to improve the obstetric results. This group might be identified and given extra care. So appropriate antenatal care which improves the pregnancy outcome. So routine antenatal care is provided at primary care facilities in rural India, and women at risk of poor outcomes are referred to the advanced centers in cities. So the primary care facilities include like sub-health centers, primary health centers and community health centers in ascending order of level of obstetric care provided. So the latter two should provide the basic and comprehensive obstetric care respectively, but they provide only the partial services. So in such scenario, the management and referrals during pregnancy are less understood. So what is high risk pregnancy is defined as one which is complicated by the factor or factors that adversely affects the pregnancy outcome, maternal or perinatal or both. So the risk factors may be pre-existing prior to this time of pregnancy, or at the first time of antenatal visit, or may develop subsequently in the ongoing pregnancy, labor or preparium. So over 50% of all maternal complications and 60% of all primary cesarean sections arises from the high-risk group of cases. So while risk cannot be totally be eliminated, so they can be reduced through effective, affordable, and acceptable maternity care. So to be most effective, healthcare should begin early or even before the conception. That is very important. We have to see the preconceptional care, and we should focus on that one to prevent the high-risk pregnancies and to improve their outcomes. So what the review says, there are large gaps in the knowledge of the emergency treatment of obstetric complications in pregnancy and pre-referral first aid. And staff generally were low in confidence and did not have adequate resources. Nurses had limited roles in the decision making on referrals, and staff desired skill building, mentoring, and moral support and motivation from senior officers are lacking. So this about the some one research has showed about the high risk uh, approach. So how we can screen the high risk cases? So we have to the cases have to be assessed at the initial antenatal examination, and preferably at the first trimester of pregnancy, so that we could able to detect as much as possible the high risk. And some risk factors may be developed later, and that is to be detected in the subsequent visits. So the cases are also be reassessed near term and again in the labor for any new risk factors. So initial screening history, the main focus here we should give apart from the routine antenatal screening, the maternal age and reproductive history and preeclampsia and eclampsia, anemia, third stage abnormality, and previous infant with RH isoimmunization or ABO incompatibility, and medical and surgical disorders if the woman has anything, and psychiatric illness, cardiac diseases, epilepsy, viral hepatitis, and previous operations, anything she underwent, and myomectomy, and repair of complete perineal tear, and repair of vesicovaginal fistula, and repair of stress incontinence. So added with, we should focus on family history also about her socioeconomic status and family history of diabetes, hypertension, and multiple pregnancies, mainly from the maternal side, and either any other congenital malformations. So according to the WHO, the high risk cases is being defined during pregnancy, during labor, and during postpartum and the newborn. So during pregnancy, it has been defined elderly primi gravida, that is more than 30 years, and short stature primi, and threatened abortion and APH, malpresentations, preeclampsia and eclampsia, anemia. Elderly grand multiparous, twins and polyhydramnios, previous stillbirth, IUD, manual removal of placenta, prolonged and instrumental delivery, pregnancy associated with the medical diseases. So during labor, PROM, prolonged labor, hand, feet or cord prolapse, placenta retained more than half an hour, PPH, and puerperal fever and the sepsis. So we have the certain scores to detect the high risk. The which one among that is Datta and Das scoring system. Here, Datta and Das score is developed this 1990. This device and which is to be used modified to assess the high risk by the Kuplan. So this is a table, the scoring Datta Das scoring system. We have the reproductive history. Uh, Under this, we have age and the parity and past obstetric history, and we have the associated disease factors and the present pregnancy factors. So each factors is given the scores 0, 1, 2. So all the scores will be totaled, and then the total score, if it is 6 and more, it is considered as high risk. And if it is 3 to 5, then it is considered as moderate to high risk. And if it is 0 to 2, then it is a low risk. So likewise, WHO also is given a simple scoring system, which they have focus on age, number of children, and the interval between the children and medical history and even maternal education. Even illiterate, they given as a score 1, and can read and write as a 0. So here again, the scoring is being given like in the points like highest risk, and they need referral obligatory if they are scoring 5 and more, and they are high risk and referral is recommended if they're scoring 3 to 4, and if it is 0 to 2, it considered as a low risk and usual care can be provided. So other scale also is available, like modified Kuplan's scoring system. Here also the scoring is been given 0 to 3 is low risk and moderate is 4 to 6 and more than 7 is a high risk. Here they focus on risk factors and medical surgical condition, past obstetric history, and as well as the present pregnancy conditions. So the why I talked about the certain scales scoring high risk scoring scales. The study of high risk scoring in pregnancy and the perinatal outcome. The study's result shows that correlation between the high risk and the poor perinatal outcomes. So the simple scoring system, such as the one used in this study, can be adapted at primary and rural health centers as a screening tool to predict pregnancies at high risk for the poor perinatal outcome. So thereby, it is facilitating for the early referral to the those cases. So what are the examination we have to do for these kind of patients? The height and weight, blood pressure, anemia has to be ruled out, and cardiopulmonary diseases has to be evaluated, and orthopedic problems has to be identified, and pelvic examination has to be done to identify the abnormalities, and uterine size disproportionately smaller or the bigger has to be identified, genital prolapse and lacerations or dilatation of the cervix, and the associated tumors and pelvic inadequacy has to be screened. Um, During the course of the present pregnancy, which has to be screened, is preeclampsia, anemia, RH isoimmunization, pyelonephritis, hemorrhage, and diabetes mellitus, post-maturity, abnormal prosternation, and the multiple pregnancy. So complications during labor to be evaluated or screened like PROM, premature labor, amniotitis, meconium stain liquor, abnormal presentation and position, disproportion floating head in the labor, multiple pregnancy, abnormal FHR, patients admitted with prolonged or obstructed labor, and ruptured uterus. Complications during the intrapartum fetal distress, delivery under GA, and difficult forceps or breech delivery, failed forceps, prolonged interval from the diagnosis of fetal distress to the delivery, and PPH or retained placenta. And certain postpartum complications like PPH and retained placenta, shock, inversion, and sepsis, which may develop in later condition. So high risk newborn is if the baby has the Apgar score below 7 and birth weight less than 2.5 or more than 4 kg, convulsions, respiratory distress syndrome, hypoglycemia, fetal infection, persistent cyanosis, anemia, major congenital abnormalities, and jaundice, and hemorrhagic diastasis. So this is the screening of the high risk cases. So now we are going to see the how we can manage or refer the cases which we can follow the high risk approach. So the high risk cases should be identified and given proper antenatal, intranatal, neonatal care, even which has to be concentrated preconceptional care. Some of the conditions as we listed, which should be treated before the conception. So this is not to say that healthy and complicated cases should not be get proper attention, but in general they need not to be admitted in the specialized centers. We know that. So their care can be left to the properly trained midwives and medical officers in health centers. But high risk cases has to be attended properly. So it is necessary that all expectant mothers are covered by the obstetric services of a particular area. So the services of trained community health workers and the nurse should be utilized to provide the primary care and the screening in rural areas and urban and semi-urban pockets. So cases with a significant high risk should be referred to a specialized referral centers. Cases from the rural areas may be kept at maternity waiting homes close to the referral centers. So cases having a previous unsuccessful pregnancy should be seen and investigated before another complication or a conception occurs. So complete investigations for the hypertension, diabetes, kidney disease, and thyroid disorders should be undertaken and proper treatment instituted in the non-pregnant state, and sexually transmitted diseases also to be treated before the another pregnancy, and cervical repair to be done even non-pregnant state, and serology of toxoplasma, IgG, IgM, and anti-phospholipid antibodies should be done and corrected appropriately when found positive. And folic acid supplement should be started non-pregnant state and can continue with the, it should be continue with the pregnancy. And early in pregnancy, after the initial clinical examination, routine and special laboratory investigation should be undertaken for these mothers. And in previous first trimester, if it is she had any abortions, it should be advised to rest and to refrain from sexual intercourse in this pregnancy, and vaginal examination should be avoided in the first trimester for these cases. And if they have suspected cervical incompetency, if they had a previous any incompetency, and if now also they have suspected incompetency, it should be diagnosed with a sonography and then in the first trimester, so that the encirclage can be performed in the appropriate time. So patients having premature labor or unexplained birth or intrauterine growth retardation and many other abnormalities are benefited by the prolonged rest in the hospital, but it should be with the close supervision. That's why they are admitted in the hospital. So assessment of maternal and fetal well-being should be done at each antenatal visit. Maternal complications should be looked for and treated if necessary. So in the management of labor, the elective cesarean section is necessary for the high risk cases in certain obstetric with the certain obstetric indications. So if they went into the spontaneous or the induction of labor, they need to be monitored progress of labor with the evidence of fetal for any evidence of the fetal hypoxia also. So if otherwise they can go for induction of labor by 37 to 38 weeks of gestation to avoid any further. So how we can strengthen the organizational support or the management for the high risk approach? So we need to strengthen the midwifery skills, community participation and referral system. Proper training of resident nursing personnel and community health workers should be focused, and arranging periodic seminars, refresher courses with the participation of workers involved in the care of these cases to be emphasized, and concentration of cases in the specialized centers for the management should be done.
Community participation is very important because without them we cannot implement the care which we planned, and then their proper utilization of the services, healthcare manpower and financial resources to be emphasized. So availability of perinatal laboratory and for the necessary investigations, availability of a good pediatric services for the neonates also to be taken care. So lastly, the improvement of economic status, illiteracy and health awareness of the community also to be taken care. So continuum of care model, that is the continuum of care over the time includes the care before pregnancy, during pregnancy and the through the most vulnerable 5 years of child's life, it is to be focused. So here the continuum of care service delivery includes integration of the health service delivery, including the care provision taught to family, services provided at the community level, outreach services and services at all facilities from sub-health post to the referral hospital. So we have a Pradhan Mantri Surakshit Matriva Abhinayan. It is an initiative of Ministry of Health and Family Welfare Government of India to identify the high-risk pregnancies early and follow them so that they can be referred to the healthcare centers with the proper facilities so that the women with the high-risk pregnancies may have a healthy pregnancies and the delivery without any complications. So let's see what are the levels of maternal care centers and what type of cares are provided in that centers. So one is the accredited birth centers. Here the care of low risk women with the uncomplicated singleton term vertex pregnancies who are expected to have an uncomplicated birth is being taken care here. So here the capabilities and healthcare providers, they could able to refer to the birth centers. So level 1, that is the basic care. Here the care of low to moderate risk pregnancies been provided with ability to detect, stabilize and initiate management of unanticipated maternal fetal or the neonatal problems that occur during the antepartum, intrapartum and postpartum period until the patient can be transferred to a facility at which specialty maternal care is being provided. So here the capability and equipment to provide the low risk and appropriate moderate risk maternal care and readiness at all times to initiate emergency procedures to meet unexpected needs of the women and newborns within the center. So this includes like emergency cesarean delivery, obstetric ultrasonography with interpretation, laboratory testing and the blood bank, and capability to implement the patient safety bundles for the common causes of preventable maternal and neonatal conditions. So like morbidities such as management of maternal venous thromboembolism, obstetric hemorrhage, and maternal services like maternal severe hypertension in pregnancy can be managed, and ability to initiate massive transfusion protocol with the process to obtain more blood and the component therapy as needed. Stabilization and the ability to facilitate transport to a higher level hospital when necessary. This includes risk identification and determination of the conditions necessitating the consultation, referral and the transfer. Next is the level 2, that is a specialty care. Here level 1 facility care which we discussed earlier. Along with that, a care of appropriate moderate to high risk antepartum and intrapartum postpartum conditions. Here the capabilities they have like level 1 facilities capabilities plus they have a CT scan, MRI, non-obstetric ultrasound and maternal echo with interpretation readily available daily at all times if not required, and standard obstetric ultrasound imaging with the interpretation readily available at all time. Level 3, this is a sub-specialty care. Here level 2 facility plus the care of more complex maternal medical conditions and obstetric complications and fetal conditions. So here the capabilities, they have the level 2 facilities capabilities plus in-house availability of all blood components and CT scan, MRI, maternal echocardiography and non-obstetric ultrasound imaging services as well as interpretation readily available at all times. And they have specialized obstetric ultrasound and fetal assessment, including the Doppler studies with interpretation readily available at all times, and basic interventional radiology that is capable of performing uterine artery embolization, to ventilate and monitor the women in labor and delivery until they can be safely referred to the ICU. So on-site medical and surgical ICUs that accept pregnant women and women in the postpartum period, and a documented mechanism to facilitate and accept maternal and transfer and the transport. And they will be providing the outreach education and the patient transfer feedback to level 1, level 2 designated facilities to address the maternal care quality issues. And they provide the perinatal system leadership if acting as a regional center. And level 4, which is the regional perinatal healthcare centers, here they have the facilities like level 3 facilities plus on-site medical surgical care of the most complex maternal conditions and critically ill pregnant women and fetuses throughout the antepartum, intrapartum and postpartum care. So they have a capability of level 3 facilities plus on-site medical and surgical care of complex maternal conditions with the availability of critical care unit or ICU beds. So on-site ICU care for obstetric patients with primary or co-management by the maternal fetal medicine team. So perinatal system leadership, including the facilitation of collaboration with the facilities in the region, always, and the review of system of perinatal outcome and quality data. Provision of outreach education and assistance with the quality improvement as needed. So that's about the levels of maternal care. So deduction of the study shows that deduction of high risk pregnancies in low resource setting. The report says that the suitable equipment, training and supervision, the nursing staff in charge of the care in rural areas can identify and refer most of the obstetric risks in time, which may contribute the reduction of maternal mortality. So to conclude the topic, so in Indian health system should be improve the provision of obstetric care by the standardizing the services at each level of health care and increasing the focus on emergency treatment for complications and appropriate decision making for referral and improving referral communication and staff support. So take home message: with the rapid advancement of the natural history of many new diseases and technology, so high risk pregnancy scoring system is the need of the hour, and the timely appropriate care for those who needs most had definite impact on the maternal and the neonatal outcome. Thank you so much for your patient listening. If you have any queries, you can ask me.
So thank you very much. Hello. Thank you very much, Mrs. Venkatalakshmi ma'am. I'm
Yes, ma'am.
happy that you had covered almost every topics related to the subtopics and related to all high risk and early detection and treatment reference for complications with a short span of time. I know it is a difficult task. However, you made it possible. I congratulate. And she has covered almost every aspect like early detection, and she has also emphasized on the risk score system. That is very important. Other than the routine care which we are giving to every antenatal woman, it is very important that we take care of the risk factors like a DAS, DATA, and DAS scoring system, WHO scoring system, and also modified compliance scoring system. All that is a newly developed, and we need to utilize it. Although it is a book stated scoring system, I think we as educators should make our students as well as in the clinical field, our staffs to practice this scoring system and be able to know it better about the deviation from the normal phenomena. And also she also covered the high risk, how to preventable disease, how can be covered with the WHO recommended approach. And very importantly, she has covered also continuum of care model, which is also we need to be emphasized on. And these are the ways we can strengthen the nursing personnel, and we will be able to, until and unless we strengthen our lower level category, we will not be able to strengthen our nursing fraternity, because they are in the community taking care of the patients, especially antenatal women, and the mothers who are in high risk has to be timely dealt and timely referred. That is very important. And also preventable maternal and fetal complications need to be detected early. For that we need to strengthen the from the ASHA worker level, we need to strengthen them. Midwifery level, it is coming at the third, tertiary level or secondary level. But primary level, ASHA workers and the ANMs need to be strengthened in this field. And that is how we can strengthen the competency of the midwifery practices. And finally, what is our ultimate aim is to have more skill in doing practicing our midwifery, which we need to be strengthened by our own skill, where we need to practice, and that can be done only in the labor room. And how much of freedom we have in our labor rooms to practice the skill is a question. And I understand one of my PhD student has developed a clinical based assessment tool in midwifery for the students, which maybe in later stage we will be utilizing it. And she has eliminated, which is also very traditional way, which is been removed, and now it has come up to a good shaped scoring as well as the tool system, which our nursing students can be utilized. That is how the skill is being developed. And we know ultimately the outcome is that our midwifery practice, competence, skill, and the knowledge is being elevated. So congratulations and thank you very much, Dr. Venkata Rashmi. And now the forum is open for any questions, and I would like to hear from you.
Thank you so much, ma'am, for your words. Thank you for the organizers for giving me the opportunity. If you have any queries, you can ask, sir. Okay.
Thank you, Professor Mariam Mujhe ma'am, for chairing this session along with our proficient speakers. Words are not enough to express our heartfelt gratitude and for giving us your precious time and conducting this wonderful session. Thank you so much, ma'am.
One more thing I forgot to tell you that, excuse me. One small thing I forgot to tell. One small thing I forgot to tell you is that pre-pregnant preparation is very important. So comorbidities like anemia, thyroid, cardiac problems, and orthopedic problem, and physical uh, problem, deformities, congenital problems, all these has to be taken care not during the antenatal period. It has to be rectified pre-pregnancy period. So these things we have to be informed and strengthened in our midwifery practice. This is the last take-home message I had to give you. Thank you. Sorry for the interruption.
Thank you so much, ma'am, for highlighting this point.
And now we will be starting with our next plenary session, that is plenary session 7, and that is care during labor and childbirth. This session will be chaired by the most dynamic personality and backbone of College of Nursing, AIM Jodhpur. I would like to welcome Professor Suresh K. Sharma. Sir has more than 20 years of experience as nurse, academician, research, and a leader, while working as a lecturer, reader, and a professor in nursing college. Then, Sir has various national and international research articles and authored in 45 books, and also reviewed research papers published 105 and books reviewed 4. Sir is also awarded with many achievements and awards. He was GNLI 2020 Scholar at Global Nursing Leadership Institute, Geneva, Switzerland, and obtained postdoctoral fellowship of Nursing Research Society of India. He also did his observership in clinical nursing research at University of York, Yorkshire, UK, and hospital management and leadership at National University Hospital, Singapore, and postdoctoral postdoctoral fellowship and University of California, USA. Thank you, sir. Over to you, sir.
Thank you so much, Fareen, for your kind words. It's my privilege and honor to be here for chairing this session, a very important session. I would like the team to display the CV of first speaker. It's my happy stage to welcome my own team member, a person behind this whole show, Himanshu Vyas, Associate Professor and Nursing Superintendent at All India Institute of Medical Science at Jodhpur. He has done his post-graduation in obstetrics and gynecological nursing, and he's pursuing his doctorate at INC WHO Rajiv Gandhi Institute of Health Sciences Consortium. He's having more than 12 years of experience by teaching undergraduate, postgraduate students. Presently, as I mentioned, that he's working as associate professor and nursing superintendent, a dynamic person. He has vast experience in conducting research. He has many awards and credits on his credit, and he is the member of many professional associations, including Society of Midwives India, and he has presented many papers in different national and international conferences. He had been an examiner for undergraduate and postgraduate courses in different institutions and universities across the country. I invite now Himanshu Vyas to speak about midwifery educators' core competencies. Floor is yours.
Good morning, sir. Thank you very much. It's an honor to be introduced by you. I'll share my slides.
I have an urgent piece of work, so I request Dr. Ashok to chair this session on my behalf by the time I come back and join the session.
Organizers, please confirm the slides are visible.
Yes, we can see, Mansuji.
Yes, sir.
Thank you so much, sir. Thank you so much, sir. My topic is midwifery educator core competencies. We have learned about core competencies of midwifery, and we have also seen that competence is the pathway to empowerment. Like in yesterday's presentation, Dr. Lily highlighted the importance of teachers, and she mentioned the word hand-holding. That is very important, that develops a very important insight and motivates us to introspect that as midwifery educators, how we are doing our part to educate our midwifery students. So as a part of this presentation, I'm just trying to highlight the midwifery educator core competencies. This presentation is basically based on the model that is the WHO midwifery educator core competencies model that is given by WHO. They have divided these competencies into 8 domains that we are going to see during this presentation. So just to introduce, the key to a competent workforce is education, and the quality of educators is an important factor affecting the quality of graduates from midwifery programs. A lot of talk and discussions are going regarding strengthening the pre-service education, pre-service midwifery education. INC, UNFPA, JAPIGO are partners in it and are involved with the ministry to set up a number of high fidelity skill labs for midwifery education so that the midwifery education and the midwifery teaching can be improved. Students can have an opportunity to experience the procedures which in the skill lab before going to the real clinical scenario. There are challenges, of course, but still the attempt is being made. So this is basically the directly proportional scenario in which the quality of educators will influence the quality of pre-service education and also the product of the institution, that is the midwives that they are producing. In this slide, we see the domains of midwifery educator core competencies. WHO has divided these core competencies into 6 domains. 2 more have been added, so total 8 domains are there. To start with, first domain is ethical and legal principles of midwifery. Second is midwifery practice. Third is theoretical learning. Fourth is learning in clinical area. Fifth is assessment and evaluation of students and programs. Sixth is organization, management and leadership. These are the 6 domains. 2 more domains are there. Seventh is communication, leadership and advocacy. And eighth is research. So total these 8 domains are there in which the competencies for midwifery educators have been divided in the WHO document. So in the subsequent slides, we are going to see these domains in detail. To start, and each domain includes the required knowledge, skill and behavior. In the detailed document, they have clearly explained what are the expected knowledge part, skill part and the behavior part in these domains for the midwifery educators. First domain is the ethical and legal principles of midwifery. First domain is the ethical and legal principles of midwifery, and the first domain, midwifery educators incorporates and promotes ethical and legal aspects of midwifery care in teaching, learning activities and by consistent role modeling. Sorry. Consistent role modeling is a very important part because students see what their teachers are doing and they try to model it. So first competencies is behave in ways that reflect the ethical standards of the teaching of midwifery professionals. Competency 2 demonstrates an understanding of the legal and regulatory statutes relevant to midwifery teaching and practice. We have seen that the ICM has launched the ethical code of conduct for midwives. So these conducts are to be followed and students learn by what they see. So role modeling of the teachers is also important to follow the ethical and legal principles of midwifery. These are the first 2 competencies under the first domain, that is the ethical and legal principles. To continue with it, domain 2 is the midwifery practice, in which midwifery educators maintain current knowledge and skills. Excuse me. In domain 2, that is the midwifery practice, midwifery educators maintain current knowledge and skills in midwifery theory and practice based on best evidence available. 2 competencies are there in this domain. First is maintain competence in midwifery practice, and second is the practice midwifery in ways that reflect evidence-based and up-to-date knowledge. So it is a very important part that midwives, along with the midwifery educators, are involved in good research work, and research work includes interventional research in which some evidence can be generated and that evidence can form the base of improving the practice as well as the education of the midwives. Third domain of the midwifery educator core competencies is the theoretical learning, which explains that midwifery educators create an environment that facilitates learning. Under these 3 competencies are there. First is incorporate educational strategies to promote active learning, select and use effective teaching and learning materials and resources. Other competencies recognize and support different learning styles and the unique learning needs of the students. It was very nicely highlighted in yesterday's presentation of Dr. Lily. Again, I am quoting that presentation because in that presentation, the title was Enriching the Labor Room Experience of the Students, and in which she nicely explained, and also the part in which she explained that what are the human inputs that can be given, not only mechanized learning, but also the human inputs, and to facilitate the students to come in an active role was explained. So in this competency, it incorporates the educational strategies to promote active learning of the students, in which innovative learning styles and methods can be used. Fourth domain of competency is learning in clinical area. Midwifery educators create an environment for effective clinical teaching of midwifery care. This is very important. At our AIMS Jodhpur also, in the last month we started with the nursing rounds, in which the undergraduate and postgraduate students were involved in the nursing rounds of the midwifery ward 2B ward. So when the students are involved and innovative methods are used, though nursing rounds is a traditional method of clinical teaching, but it is not practiced that much. So when the students are given an insight that you have to see these 3 patients and you have to present these 3 patients when your clinical instructor comes to your area. So they go through it and they try to explore it more deeply. What are the parts of that, or what are the parts of that case, what is the treatment diagnosis, what is the nursing care part that is at times remains ignored. So when the students are doing the case studies, they only focus on the medical part, the treatment part, diagnosis part, and the pathophysiology part. But if a single case is always focused on the nursing diagnosis and management part, then the student develops that what is expected of them if they are treating a case of gestational diabetes or a pregnancy-induced hypertension, what nursing care they are expected to provide. So they develop an insight and they get an opportunity to introspect or think over it, what nursing aspect can be focused on. So in learning and clinical area, two competencies are there. Competency 8 is facilitate a safe and effective learning environment in the clinical setting. Competency 9 is foster individualized experiential learning. So for these things, there are challenges, but still the challenges have to be met. There are challenges, as Madam Celsi Mary was rightly saying, that labor room exposure is also limited. They are getting less opportunity to practice, and the number of students in one batch of clinical group is also increasing. In spite of these challenges, in our skill labs, we can try to provide them with the individual experience. And while they are in the labor room or the clinical area, to the extent possible, we can provide them a safe learning environment and individualized learning experience. So that is also a very important part. Then competency 5 domain is assessment and evaluation of students in programs. So it is also a very important competency of the midwifery educator. Midwifery educators are responsible for conducting regular monitoring, evaluation, and assessment of programs and students. Competency 10 says that continuous monitoring, assessment, evaluation, the effectiveness of the educational program, and assess the student competence. While assessing the competence of the students, innovative methods of assessment, including simulation, including the OSCE, OSCLR, these methods to be used so that individual opportunities given during the practical examinations. At times we see that during the practical examinations, the students are not assessed as expected. So what happens is they easily clear through the examination. So during the assessment, if OSCE and OSCLR are used, at least they can have individual experience of that procedure. So that is very important. Then next domain of the competency is organization, management, and leadership. In this domain, midwifery educators participate in formulating policy and program outcomes and in designing and implementing curricula. So this is also a very important part, like we will see in the further sessions. And in yesterday's session of Professor Suresh sir, we see that the midwifery initiative in which the midwifery practitioner program has been started. So if midwives, educators are included in the curricular development, that is a very important role to be played by them. And its competencies include that active participation in organizing and implementing a midwifery curriculum, implement and revising the midwifery educational courses and programs. That is also a very important competency of the midwifery educator. To proceed to the seventh domain of midwifery educator competencies, that is the communication, leadership, and advocacy. In this, 4 competencies are mentioned. That domain reads that midwifery educators are effective communicators and function as advocates, change agents, and leaders. And competencies include communicate effectively using a variety of methods in diverse settings, demonstrate cultural competence in course design and development, teaching, and midwifery practices. As practicing midwives and as midwifery educators, we should educate and inculcate the midwifery students with the cultural background, with the diverse patient population, what is expected of them, and communication part is also a very important part. Like we see that most of the pregnancies are normal and physiological. So if the midwifery communicates in a very clear way and they tell them, because in primary gravidas there is a fear. So midwifery educators, students believe that pregnancy is a physiological event, and when they communicate with the antenatal mothers, they are able to make the mothers understand that it is a physiological event, and they know in advance what to expect during the different trimesters of pregnancy. as well as what are the warning signs and when they need to contact the doctor immediately. So these things are very important, and that can be done through effective communication. The next competencies in the same domain are function as change agents and leaders in order to improve both midwifery practice and midwifery education. This is a very important competence in which we see that institutes like St. John's, Choitram, and or other institutes have volunteered in taking the midwifery initiative, and leading the midwifery care. They have their own midwifery led antenatal clinics, internatal clinics. So this we envisage for our future, but at least the vision should be there of the midwifery educators that they can function as change agents and leaders in order to improve both midwifery practice and midwifery education. As midwifery educators, we also face challenges in our clinical area. At times we see that resistance is there from the medical faculty also, or the administration also, that your students cannot practice independently. So these things are going to be there because ours, or as the institution is a tertiary institution, so only high risk cases are there. So their concern is also correct. So we have to develop an understanding that these are our UG students, these are our PG students. These things UG students can do and these things PG students can do. If this is properly communicated, then the situation can be improved. Competency 7 is a use of a variety of advocacy strategies to promote midwifery education and practice, including professional, community, human rights, and structural advocacy. So that is also a very important competence in which advocacy strategies are to be used. To move to the last domain of this competencies of midwifery educators, the last domain is research. Though it is the last, as it has been added afterwards, but this is the domain which will help the midwives to be competent. If midwives undertake interventional research, and I can understand it can be little difficult at our independent level, so we can collaborate with the medical faculties, we can collaborate with other streams, and we can take some interventional research in these simple interventions. Like at our AIMS Jodhpur, we have taken simple interventions including the birth positions, the birthing ball exercises, the squatting position, the perineal massage. So these simple interventions we have tried to take in our PG projects. So that can be a very important competency of the midwifery educators. So domain 8 reads that midwifery educators promote the use of research and use it to inform midwifery education and practice. So use it to inform, that is the whatever research is done, it should be published. It is well said that if it is not published, then it is not done. So once it is done, it should be communicated, and the so the scientific society should know what research has been conducted, though it is done at a small sample size at PG level, but still it can form a base in some systematic review, or it can form a base for a larger study. Then competency 18 is use research to inform teaching and practice. And competency 19 is cultivate a culture supporting critical inquiry and evidence-based practice. The term culture here is very important, and it is the way we motivate our students to practice. It's not like that only 20 deliveries they have to conduct or 5 episiotomy they have to do. It's like that they can understand why it is important, and even if they are getting a chance to do 2 deliveries, they can develop an insight how and what is expected of me in these tasks. So these are the 8 competencies, 8 domains. So my presentation basically focused on what are the core competencies of midwifery educators. It was not on the part that how to develop these competencies. So this presentation takes us through the orientation to the core competencies of midwifery educators. That was based on the WHO document and endorsed by the ICM. Building capacities of midwifery educators is a vast area, and further workshops can be organized on this theme. And I am very happy to share that Indian Nursing Council, along with the ministry and JAPIGO, are conducting virtual as well as in-person simulation trainings and doing the capacity building of midwifery educators around the country. This is a very good opportunity, and I request all the participants, all the midwifery educators who are participating in this conference to register for those workshops, and this is a 6-day course in which they are running at the SDT University, National Reference Simulation Labs Center. And this is a very good course that develops the capacity building of the midwifery educators. So this was all about my presentation, and to conclude the presentation, competence is the pathway to empowerment. If we want to empower ourselves, we have to be competent. Thank you so much.
Thank you so much, Mansuji, for a wonderful enlightenment towards competencies expected from midwifery educators. I'm back here, so I'll take up the next speaker and we'll take questions together in the end of 3 presentations. CV of the next speaker, please. It's honor to invite Ms. Talitri Sawan, Assistant Professor at College of Nursing, All India Institute of Medical Sciences, Bhubaneswar. Madam has done her Masters in Obstetrics and Gynecological Nursing and PhD scholar at the moment at INC National Consortium. Madam Talitri is having more than 15 years of teaching experience, and she has conducted many researches, including ICMR and DST projects. She had published more than 33 research papers in index journals. Madam has been awarded RULA Award, Research Ratna Award in year 2019 for outstanding contribution in field of research, and also awarded as one of the accredited member of the World Research Council for academic year 2019 and 20 by Senate of World Research Council. She has authored 4 textbooks in the field of obstetrics nursing, nursing management, basics of genetics, and also contributed several chapters in books in the discipline. I invite Madam Talitri Sawan to speak on the topic.
Good morning to all. So thank you, sir, for your kind introduction. So let me congratulate the organizing team for hosting this type of apt conference for this platform. And I'm so honored to be here as a speaker to talk about the topic, this manage a safe spontaneous vaginal birth. Next. So these will be the aspects I'll be talking in my sessions. So first will be the organizing the labor room. Next will be the safe childbirth practice, normal vaginal birth process, and evidence-based maternal and newborn care practices for a safe vaginal delivery, interpartum care competency for managing labor and childbirth, then harmful practices during labor and childbirth. Next. So let's see, like before going to the main topic, so let's have a glance on mode of delivery. So we have seen that like along with the medical indications and doctor's preference, study reveals that women's preference also is one of the factors which is increasing the elective cesarean sections. So recently we have conducted a study by undergraduate students. We found that the vaginal birth was preferred by 58.5% of subjects, whereas cesarean was preferred by 28.5%, and 13% wanted physicians to decide their mode of birth. So here we found that greater percentage of Indian women had a positive attitude towards normal vaginal birth, but their preference was high if we compare with the standard cesarean rate, that is 15%. So here we found that the women were preferring towards undergoing mode of delivery, that is cesarean. Why? Because they feel that cesarean is more safer than normal vaginal delivery. And sometimes they express that the labor room experience is not conducive, and they find the pain is not properly managed, and they were not taken care. So many like experience we have received from the mother. So here I feel the role of midwifery comes. So already we know that the stages of labor, that is first stage, second stage, third stage, and fourth stage. So first stage starting with that contractions and all, and second stage we deliver the baby, that is explosive stage. Third stage we deliver the placenta, and fourth stage, that is the maternal
For the clarification, please bear with us for 2 minutes.
Resume.
Go to the third slide, please.
Sorry for the
Yes, yes, before that, yeah. Okay. So these are the stages mother has to, the labor journey has to start with contraction, delivery of fetus, delivery of placenta.
क्या करो
I request every participants please kindly mute yourself.
You can continue, Madam. Continue, Madam Darshi. Madam Darshi, please unmute yourself and continue.
Yes. Next slide, please. Yeah. So before going to the labor delivery, like bringing the woman to the labor room, so we have to see that the room is well organized. It is well prepared. So what are the things we have to see that labor room is organized? Mostly we see the temperature. It has to be the temperature between 26 to 28 degrees centigrade and it must be draft free. Another is that we have to see all the equipments must be checked for its functionality before you conducting any cases. Also, you have to use the sterilized instrument for each cases and see that all the members of the labor room practices and adhere to the infection prevention controls or protocols. So along with that, so many trays like labor trays has to be kept ready in the labor room so that without any wasting the time, we can conduct the delivery. Mostly the delivery tray, episiotomy tray, baby tray, medicine tray, and emergency trays. So all the trays has to be kept ready. So before you are taking over any cases to the delivery room. So that is very much important steps. Next, we'll see how we can have a safe childbirth practices in labor room. So now WHO has implemented, it's under process to utilize and implement the WHO safe childbirth checklist. If that checklist is implemented in the labor room, really we can have a safe childbirth practice in our labor room. So here it starts with admission, not during after bringing to the labor room. To start the work at admissions. From the admission point of view, you have to do the initial assessment and you have to do the triaging, like who are the complicated cases has to be separated, has to be managed, and who are the normal cases who will undergo the normal vaginal delivery has to be planned, identified at the level of admissions. Okay, and some also in a first stage, we have to do plotting of pathograph, and also we have to see that mother is having a companion along with her to get the support throughout labor. That is most important aspect has to be done when mother in at admissions. Same thing when mother will be brought to your labor room or on the labor table. So see that what has to be done, the preparation for delivery, like all the kids has to be ready, labor room has to be ready, that newborn corner care has to be ready, all the preparation has to be done. And you have to see that a pre-filled oxytocin is there, and if, the midwifery who is conducting, and she has to be very competent to do the active management of third stage of labor, and baby has to be kept with this one to give vitamin K, and should be practice exclusive breastfeeding, essential newborn care, if baby needs any resuscitation, that is newborn resuscitation has to be done, and routine mother care can be given. Like same thing just after delivery, also just after birth. So PPH assessment is very important aspects. The bleeding has to be assessed whether mother is undergoing any bleeding. So that accordingly the management has to be done. Or mother need any antibiotics or newborn needs any antibiotics, accordingly any referral has to be done. That also to be identified to be at the early stage so that mother should not go any complications. Same time, it's not stopping, we have to go discharge. At discharge also we have the role. Same thing, family planning counseling has to be given, and PPS assessment also has to be done. The secondary PPS can be happen at the discharge level also. And same time during discharge, you have to say that we have to identify any danger signs of the mother newborn is there, accordingly referral has to be done. So these are the are the checklist. If the midwifery maintain it, so really we will not have any issues like like immediate complications mother may not face, and mother will have a real experience of good childbirth experiences. Next. Here. So another good aspect, a really important aspect is monitoring the progress of labor. Okay, so already in the last like talk, so somebody has told that about how to plot the WHO pantograph. It is very important. If the progress of labor is good, if mother is progressing in normal way, so like that we can ensure that mother will undergo a normal vaginal delivery. It is without any complications. So now WH has replaced with another that is next generation pantograph, that is LCG, that is Labor Care Guide. It is under implementation. And study says that implementation of LCG has a very better maternal and fetal outcome. So let's see what the difference between two. Next slide. Let's have a glance what the difference between two, that is WHO pantograph and WHO Labor Care Guide. So mostly we have seen that, so active phase we starts at 4 centimeter in WHO pantograph, whereas LCG they started active phase at 5 centimeter dilatations. And another important aspects that in WHO pantograph we do, and we are be so alert and do actions where the dilatation comes below 1 centimeter per hour, will be so alert. Whereas in LCG, it is not taken as a very big trigger to go for any interventions. So they told it is shown that evidence-based time limits can be fixed to take the proper actions related to cervical dilatations. In WHO pantograph, no second stage sections is recorded, whereas LCG, there is intensified monitoring in second stage is included. And another important aspect is supporting care, that is companion, like it's for the mother's choice. So it is not there in WHO pantograph, whereas in LCG, so there is more emphasis is given the companionship. And there will be there will be opportunity for pain relief method. Mother can take the whatever pain relief method she wants, oral fluid intake and posture as per her wish. So that was all included in LCG. Another important is uterine contractions. So mostly in WHO pantograph, we record strength, duration, frequency of uterine contractions. Whereas in LCG, the strength is removed. Why? Because really practically to measure the strength of uterine contraction is not possible. So they have done only the frequency and duration is enough to see the any deviation of uterine contractions. And the last one is that so all labor parameters, any deviation in labor parameters was not taken care except cervical dilatation, alert and action lines. But in labor care guides, each labor parameters, any deviation in each labor parameters was taken care, recorded and reported to the care providers to take the immediate actions. So these are the difference between these one things. So next comes, so after you are seeing that mother is progressing labor normally, said how to conduct a vaginal delivery. So with all the steps everybody knows, engagement, then flexions, interrotations, crowning, extensions, restitutions, delivery of shoulders. So here I'll just highlight what are the important aspect we must remember when conducting a delivery. First thing you have to see that you ensure that privacy, dignity of the mother and mother is comfortable. Another important is that all the equipments, medicine, disposables are ready in the delivery room. And in active stage of labor, mother has to encourage to ambulate if my membrane is not ruptured. She should not be lying down in the labor table unnecessarily. So she can ambulate it so that it will help in the progression, help in dilatations. And another important is that you have to encourage the mother to push. And before that, you ensure that the woman is well hydrated and bladder is empty. If bladder is not empty, if she is unnecessarily she's pushing, it may lead to the bladder injury. So that has to be taken care of to remember while you conducting delivery. Another one is after each contractions, mother has to encourage to take a breath through her mouth, and we have to talk to the mother. And another important aspect is that when to talk to tell that mother has to bear down. That has to see that the head is visible. That means crowning has occurred. Then only we have to encourage the mother to bear down. And next is to support the perineum to prevent perineal tears. That is very important because most I've seen that like mothers are going for first degree, second, third degree tears because of not supporting the perineum properly. So perineal support and urethra support to be given continuously so that flexion of the head will be maintained and will prevent the perineal tears. Then you have to deliver the anterior shoulder followed by posterior shoulder, and then the deliver the mother on mother's abdomen, not bringing to the warmers. It has to be, baby has to be put in the mother's abdomen. Another important core of the competence is that active management of third stage of labor. When baby is delivered, next our term comes to prevent or to manage PPS, to prevent manage PPS or bleeding. So these are the four components has to be midwifery has to well known and has to practice. So first is administration of injection oxytocin 10 international unit IM within 1 minute of birth of baby, or misoprostol 1600 microgram orally can be administered within 1 minute of birth of baby. Next is clamping and cutting of the umbilical cord. So sees that whether mother needs a delayed cord clamping or early cord clamping, so that has to be decided, and perform the control contraction. That is very important. Control contraction procedure has to be conducted to be done, and perform uterine massage with a cupped palm until uterus is contracted. These are the four important aspects to be done for the active management of third stage of labor. Once baby is delivered, already I told that baby has to be put on the mother's breast. So breast crawling is nowadays is very good aspects, very good competency to start the early breastfeeding within first half an hour. So we have our one PG students has conducted study on standard breast crawling procedure. It has shown a significant improvement in maternal newborn outcomes. So baby has to be put on the mother and to start a natural breast crawling. And we found the good outcomes like early initiation of breastfeeding, that is mean duration was 23.1.8 minutes, less than 25 minutes, and there was a good latching ability was there, and that is early expression of placenta, that is less than 30 minutes, sorry, from 5 minutes, and there was less episiotomy suturing pain. Mother experienced less episiotomy pain. There was less amount of blood loss, and there was also early involution of uterus. These are the very good outcomes we found due to the breast crawling. So it has to be practiced by each midwifery. Another concept is delayed cord clamping. Already I told that clamping the cord, really the many studies has revealed shows that cord clamping has a very good effect on hemoglobin increase, and cord has to be clamped in two places, like first clamp maybe in 2 fingers away from the umbilicus, second clamp will be 5 fingers. So delayed cord clamp has to be practiced. That is we have to delay 1 to 3 minutes. And we have also seen one another PG students conducted study on delayed cord clamping. We also found that is good maternal newborn outcome, and there was high like increase of hemoglobin and bilirubin level of units very significantly higher with disease at 3 minutes compared with disease at 1 and 2 minutes. Whereas we did not find any difference in the need of phototherapy. Though bilirubin level was high, but there was no significant difference to need of phototherapy among 3 groups. Whereas hemoglobin level was high in the disease 3 minutes. So delayed cord clamping has to be practiced, and it has a good evidence. Next. Yes, another aspect is delivery of the placenta. The third stage, then we have to see how to deliver the placenta, and that is it's written that control contractions. Control contractions study says that it reduces the risk of postpartum blood loss. Also, it reduces the duration of the third stage of labor, and it decreases the need for manual removal of placenta. So, how it will be conducted? Though everybody talks about how to do the control contraction, but how to be do, so that some aspects I put it here. So you have to like hold the clamp cord and end in the forceps with one hand and place the other hand just above the woman's pubic bone for counter traction. Counter traction is very important. We give a tension on the cord and we'll wait for the contraction. Once contraction comes, so during contractions, gently pull the cord downwards to deliver the placenta, and same time, in the other hand, push the uterus upwards by applying counter traction. So counter traction has to be there. If without no counter tractions, placenta will not deliver within 5 minutes, and that may lead to PPS, bleeding may occur. So it is very important to practice how to do a controlled contractions. Next. Yes. This is after delivery, the baby has to be sent to that is newborn corner care. So every labor has a setup, has to be one newborn corner care. All the instruments, all the equipments has to be ready, warmers, and if we need resuscitations, the bag, ambo bag, and shoulder roll, then suction machines, oxygen cylinder, and to provide essential newborn care, all the equipments has to be ready in the newborn corner care, so that without wasting time, baby has to be taken care, or if baby needs resuscitation, she has to be resuscitated, and immediately baby has to be wrapped and give to the mother for early initiation of breastfeeding. So this is as another aspect. So the not cell, I have put it, that is what are the each stage, what are the evidence-based maternal newborn care practices has to be implemented by midwives for if during for a safe institutional delivery. So if first stage, already many things I discussed, just in that once more I'm repeating. So first stage, you have to encourage the women to move out, that is ambulations, avoid routine enema and saving of the pubic hair. And where there is no facility for cesarean sections, we should not do the induction or augmentation of labor. Always monitor labor using a partograph or LCG, whatever is implemented in that labor room, and restrict the PV examination, vaginal examinations to once in 4 hours. Same thing, second stage. So the positioning is very important. It's not that just lying the mother on the bed. So she can take her own choice, comfortable choice of position, that is sitting or squatting. Now it is highly recommended, and avoid routine episiotomy for prime gravidas, and do not apply abdominal pressure to push the baby out. Most it is a practice, we push the abdomen when baby has to be delivered. And another important is that we should not be very rushed to complete the second stage within 1 hour if the mother fetal heart sound is normal. If it is normal, we should wait. Normally, it has to be completed. And another is that always wash hands before handling women or a newborn. This is the second stage evidences. And third stage, so that is immediately after third stage, already I discussed active stage management. Active management of third stage level has to be practiced, that is oxytocin has to be given IM, control contractions and uterine massage is must. Then if got the cord after it stops pulsating, or that is delayed cord clamping, if fetal mother baby like there is no need of resuscitations or mother is RS negative. Other cases we have to go for delayed cord clamping. We should not do the packing of vagina. And another aspect is try and wrap the baby immediately after birth and cover and place it on mother's abdomen. And another good aspect is that we should not do routinely nasopharyngeal suctions unless liquid is meconium stained and all. So we should, if at all it is necessary, we should do the manual mucus sucker instead of electrical suction machines. Then after delivery, so monitor maternal bleeding and vital signs every 15 minutes in the first hour, and every 4 hours in the first 24 hours, and it has to be monitored to check the PPS or bleeding for the mother. Then initial breastfeeding is the earliest, that is within half an hour after birth. Wrap the baby and keep close to the mother. Discharge after 48 hours. If mother or baby have any issues, then you can delay the discharge for a few days. So here WHO also brought a very good model, that is WHO intrapartum care competencies. Here 9 competencies nicely it is reflected. So what are the most important aspects, like the mother should to have a positive childbirth experiences. Mostly respect and dignity has to be maintained already. That topics already covered. Respectful maternity care, that is very most important, and WHO given more emphasis on respectful maternity care. And companion of choice mother has to be supported with the companion like for the throughout labor, and clear communication by maternity staff. Pain relief strategy has to be given to the mother to relieve pain. Labor pain management, and mobility in labor and birth position of the choice. These are the very good aspects reflected in WHO intrapartum care models. So what are the harmful practices has to be avoided? So just I have put some points. So we should not see that unnecessary pushing in between contractions should be avoided. Ensure the woman is hydrated and the bladder is empty before encouraging the woman to push. Avoid routine augmentation of labor before delivery without any indications. Do not perform routine episiotomy mostly in prime gravidas. No oxytocins or other heterotonics for unnecessary induction or augmentation of labor. This is very harmful practice has to be avoided during delivery. So the last I have got before. So at the last, I have put that what are the key recommendations for the labor practice. So these are the recommendations already I discussed, just I put in the last slides. So like that the positioning is very important. Okay, the promote walking and upright positions for the mother in the first stage of labor, like kneeling, squatting and standing. So many studies are going on, and they have got a very good outcome when the position is like this, instead of lying down, these positions are practiced. And provide continuous support during labor and delivery, that is companion to be given to the each mother. and offer warm perineal compress during labor. It is really has good outcomes. And delayed cord clamping to that is 1 to 3 minutes after birth until cord pulsation has ceased, unless urgent resuscitation is indicated. And consider intermittent electronic fetal heart rate monitoring. That is, you should not go continuous fetal heart rate monitoring because it creates so much anxiety with patient. If mother is not having any risk factors, she can go for intermittent electronic fetal heart rate monitoring. These are the key recommendations for safe delivery and safe practices. So these are the things which I covered. So if any questions, any queries, you can ask. Thank you so much for this question listening. Thank you.
Thank you, ma'am, for the wonderful session.
Thank you so much.
Ma'am, there are a few queries we have received in the chat box.
Yes.
So this is a query by Sarita Rawat, ma'am, and she is asking how we will be decide the dose of misoprostol in third stage of labor.
Yes. Once more, please tell me. Repeat the question.
The question is,
Yes.
how will we decide the dose of misoprostol in third stage of the labor?
Yeah, so no, this is for preventing that PPS bleeding. So we are administering oxytocin IM. Suppose it is not given, IM is not available, and also orally also misoprostols can be given as a prophylaxis to prevent PPS. So it is a recommendation by Minister of Health and Family Welfare. It is a recommendation. It can be given if it is IM is not available.
Fine, thank you so much, Madam Tharatri. There's another question: WHO partogram versus LCG.
Yes.
Which one is to be followed?
Yes, sir.
The next question, the participant Sonia Kumari is asking from you.
Yes, ma'am.
WHO partogram versus LCG. Which one need to be followed in practice?
Is shown that LC is going, it has a very, very better fetal and maternal outcome. So it is going to be implemented. Many like centers has also, they have adopted LCG. So it has the components already I discussed. What are the extra components are added in the WHO partograph? It is a next generation partograph. It is not completely they are removing. It is just addition of the previous WHO partograph.
Fine, thank you so much, Madam Tharatri. Now, if there will be any questions at the end of the session, we can take up.
Yes, thank you.
I request to display the
Thank
CV
you,
of the Madam Dr. Asa Sethi. It is my honor to invite the next speaker, Dr. Asa Sethi, Professor and Principal and Chief Nursing Officer at All India Institute of Medical Sciences, Bhubaneswar. Madam has done her post-graduation in child health nursing, her MPhil and PhD in child health nursing. Madam had a vast experience as a tutor, assistant, lecturer, professor, dean, principal, and additional responsibility as a chief nursing officer at AIIMS Bhubaneswar. Madam has undertaken funded and non-funded research projects, published many articles in Index Journal, and been resource person for many scientific sessions in regional, national, international conferences. Madam has been awarded many awards, and she is recipient of Excellence of Professional Contribution award conferred by K. Pandaraj Balla Institute in 2013. Madam is also recipient of Vidya Seva Ratan Award by the Others Play School in 2012 in the Division of Social Services. Madam, I invite you to speak on evidence-based newborn care. Please.
Good morning to all of you, and thank you very much, Dr. Suresh Sharma, for introducing me. It's a pleasure that to be on this August platform to be with you all. And at the outset, my hearty congratulations to you as well as all the organizing team members for such a beautiful ICM conference. So, as you have already, the participants, I once again welcome you to this next session. And uh, Madam Rajrani also, my warm wishes of morning, good morning. Okay, as we proceed with this session, all the participants, as you have attended very enlightening the previous session, where the spontaneous management of spontaneous labor, vaginal birth. So now, in continuation to this, we are discussing about the evidence-based newborn care. As a few aspects of it have already been highlighted by the previous resource person. Let me know whether I have to share the PPT or you're sharing from your side.
Ma'am, I will share from our side.
Yeah, please. Thank you. So this session we will be talking a little bit about the evidence-based care of the newborn. Can I have the next? Okay. So the in this session, the learners will be able to explain about the evidence-based newborn care. Though there are so many new evidence-based practices based on the time that permits us, we will be discussing a few of the evidence-based newborn care practices. When we talk about the evidence-based newborn care practice, um, it is in general evidence-based practice means it is increasingly using the that is describe it increasingly this term is used to describe the application of empirically acquired knowledge in the practice. So if we look at the neonatal practice, more than 70% of the current deaths that could be prevented based on the practice of the evidence-based procedure. Because in when we talk about the newborn health, the infant mortality rate, this is what that comes to our mind, which is very high in almost all the states. And many of these things can be easily handled by nurses themselves without any, high tech care. But what happens is the basic areas of evidence practice in neonatal care, there is still limited information that is available. There could be lack of knowledge about these evidence-based practices among the healthcare professionals, and also because of this fragile population, their needs are not considered like to what extent that has to be considered by all. So can I have the next slide, please? If you look at this slide, the neonatal mortality rate, it's very high in many of the states. And it is everybody has to work towards this to bring down the neonatal mortality rate. Can I have the next slide, please? So there are various causes of neonatal deaths in India. So the causes could be attributed to either it could be antepartum, reasons, or it could also be related to the causes which are happening during the birth of the newborn, or it could be after the birth of the newborn. But it's very, very essential that at the time of the birth, that the care that what the newborn gets is, that will have a long impact on the life of the newborn. As we see in this slide, the graph that shows, though the infant mortality rate, the newborn mortality rate, the early neonatal mortality rate, so all these have been taking there is a reduction in this if we see from year 2000. This graph shows up to 2013. So this is based on the data that was collected in a study. So still we have a long way to go in this regard. So that is because more than a quarter of global neonatal deaths, which are reported from India, and a large proportion of these deaths, they are preventable. That is especially like practicing a few evidence-based practices, that is, hand hygiene or managing asphyxia. So many of these things can be managed by nurses themselves, and thus we can reduce the neonatal mortality rate. So there is a large gap that exists between what people know and what that is to be done or practiced. So that is because the gap between the evidence-based practices and what we, the knowing and what we do in the practice. So let's take like some of the practices that can easily be implemented in our day-to-day practices. So when we talk about breastfeeding, which is very important for a newborn baby, and which has to be immediately initiated for as early as possible, soon after the birth. And we know that the breastfeeding that reduces around 22% reduction in the newborn mortality. The breastfeeding has to be continued for at least 6 months. That is exclusive breastfeeding, the demand feeding that is to be given. And it is, everyone knows that colostrum is important, which also boosts the immunity of the newborn baby. But we see in our practice, in our including the professionals, that giving pre-lactal feeds to the newborn, and this is one of the cause that where the infections in newborn are increasing. So we need to be aware, as well as we need to communicate this information to the mothers and the family members, that no prelactal feed should be given. And at the same time, while a mother is breastfeeding the baby, also the mother has to adopt the proper techniques of breastfeeding. So which is one cause that baby is not getting adequate breastfeeding, because we need to educate them. A good feeding, that is an indication of the general well-being of the baby. A baby gets adequate feeding means baby's all the anthropometric measurements will be in normal. And at the same time, breastfeeding, the mother is also benefited because it is a natural method of birth control. It also reduces the risk of breast and the ovarian cancer. So can I have the next slide, please? So as we are talking about educating the mother about proper feeding, that we have to tell the mother how to hold a baby. Even when we go around the ward, we have to educate them. So how the baby's body has to be, how a baby will be facing the mother's face. So baby's body is close and facing the breast, where the baby has to, the mouth has to be wide open, the lower lip is the areola is more visible upper in above. So it is where the baby is latching properly to the breast, so the baby will be able to get adequate milk. Whereas if the baby is not positioned properly or not attached properly to the breast, that mother is not focusing or mother is not looking even at the baby's neck is twisted. So we see there is, the baby is poorly attached to the breast, and gradually what happens, the baby will not be able to get adequate breast milk. And what happens if a baby is not getting adequate breast milk, naturally the baby will be irritated, and baby will not sleep, and that will affect lot more things. The mother's health will be affected, no proper sleep, etc. Baby's growth will not be proper. So this is why, like, we are not going previous slide please, not this one, don't change the slide please. Okay, so breastfeeding is one of the important thing that we have to consider in our day-to-day practice. So when we talk about the breastfeeding, it is irrespective of the any illness of the mother. If the mother is in a healthy condition, it may be mother may be in ill condition, but if the mother is able to breastfeed the baby, it is a responsibility, knowing that what are the benefits of the evidence-based practices, knowing, having the knowledge of breastfeeding, advantages of breastfeeding to the baby, we have to ensure that the mother will continue to breastfeed the baby exclusively for 6 months. because even if a baby of a HIV positive mother, when we analyze the risks and benefits, so baby has more advantages of receiving breast milk from the mother than getting the other, replacement feed. So we have to encourage the mother for breastfeeding, even if it is a COVID positive mother. So there is no restriction that a mother cannot feed the baby. So as if the mother is critically ill, then maybe if the mother is in a position to express the breast milk, so at least that we can encourage the mother. So here one of the practice that we have to emphasize in our day-to-day practice is exclusive breastfeeding the baby, and also early initiation of the feeding to the baby soon after the birth. Next slide, please. The second practice, what we can just discuss a little bit, is about suctioning the neonates at birth. I'm sure all of us, like who have studied this obstetrics and gynecology, this midwifery many years ago, we have learned that as soon as the baby's head is out and the baby is born, we need to do the suctioning of the, so that the baby's airway is maintained, patency is maintained. But as for the evidence-based practices and WHO recommendation, the suctioning of the neonate at birth is not recommended. So here the indication is that whether the baby is crying or no. If the baby is crying, then the suction of the mouth and the nose is not necessary. Next slide, please. So here the practice, evidence-based practice in newborn care is we need to stop suctioning of the neonates at birth, because this indicates that there is no benefit of this practice, and that causes bradycardia and apnea in newborn, because many a times the suctioning that will lead to vigorous suctioning and that leads to apnea. So then instead of suctioning, it is just enough to wipe the baby's mouth where there are secretions and also nose with the towel, so that the excess secretions can be cleared, and that will stimulate the baby for respiration also. So now when we say no suctioning, but if the baby is with any meconium aspiration or risk of amniotic fluid aspiration, in those cases, if the baby is not crying, then the suctioning is essential. So many studies have shown that there is no difference in breathing after wiping or suctioning, and wiping is considered preferable than suctioning. So wiping these secretions with a towel is as effective as suctioning. There are also no adverse effect of wiping, and wiping is not best if a baby neonate's airway is blocked. That is what if there is any risk of aspiration, and if the baby has not cried immediately after the birth, then the suctioning has to be done. Next slide, please. Then next, let's talk a little bit about temperature of the newborn. So where we have to maintain the warm chain. So this applies from the time that we receive the baby soon after the birth, and maintaining warmth for the baby. As in the previous session, the resource person said the baby has to be put on the mother's abdomen. And while receiving the baby also, we need to see the environmental temperature, that where the baby is born, the birth is taking place, the temperature has to be maintained. At the same time, the surface upon which the infant is placed, so we need to see that adequate, that is warmth that is maintained. And also we have to take all the precautions so that the heat loss at the time of the birth is prevented, so that the baby is not going into hypothermia. That when we are receiving the baby, we need to have the pre-warmed clothes that to receive the baby, and we need to dry the baby, we need to cover the baby adequately. Even while taking the baby for weighing, we need to see that the baby is not placed directly on the weighing scale. Or even while feeding the baby has to be adequately covered. Maybe the cap or the socks and the additional clothing that what we can use for the baby, so that the warmth that can be maintained for the baby. Next slide, please. Another important aspect that when we talk about the evidence-based practices is bathing the newborn baby. So this is one of the important and interesting topic in case of newborn health. So earlier, like even when I was a student, I remember bathing a newborn was, it was very much interesting, and removing the vernix caseosa, making the baby very clean and mummifying and handing over the baby to the parents or the relatives. But as for the evidence-based practices, bathing the newborn to be delayed at least for 24 hours. But in case if it is not possible for 24 hours, so at least 2 to 6 hours the baby bath to be delayed. And if the baby is a low birth weight baby or a preterm baby or a high risk baby, the baby bath to be delayed at least for minimum of 7 days, at least for 1 week. Even while bathing the baby, we have to see that we have to have the room warm, we have to have the warm clothing, the water also to be warm, and baby to be immediately quickly to be dried, and thoroughly the baby to be dried, so that there is no loss of heat from the baby's body, and nicely the mummy to be mummified baby with adequate clothing, and baby to be handed over to the mother for breastfeeding. Next slide, please. Then so these are the practices which we need to not only practice in our hospital setting, but also we need to educate the mother so that the newborn health is promoted. So keeping the baby, newborn baby, the preterm or sick babies, they also to be kept warm, and especially we have learned about the skin to skin contact with the baby and the mother, where we immediately after baby's birth, we put the baby on mother's abdomen, and we promote skin to skin contact with the mother and the baby. And everywhere, wherever the baby is placed, whether in home setting or in the hospital setting, we need to prevent the heat loss. And even while touching the baby, we have to see that our hands are warmed up, and we have to see the baby is not placed directly on any cold surface, or all types of heat loss that happens in a baby, that has to be prevented. And even at home, it is very particularly that we have to encourage them, because why I'm saying this, many a times mothers are not able to identify how does it feel to be like when a baby goes into hypothermia, and what need to be done when baby goes into hypothermia. So these are the practices in case of neonatal health. It does not require any high-tech care or facilities, but these all practices can be carried out even in home setting by simple education and by practicing what we know that we can do. So next one, please. So same way we need to monitor the babies, even if the baby is suppose kept under the radiant warmer. Suppose if the baby's body temperature goes high, so we need to immediately monitor so that the baby's body temperature is maintained within the level. And also, even if the baby is in incubator, or if the baby is left alone somewhere, so we need to monitor the baby adequately so that the baby's body temperature is maintained adequately. Next slide, please. So simple thing as we talk about the kangaroo mother care, that is, as we already said about the skin to skin contact, this is about the kangaroo mother care. It is little different than that of the skin to skin care, which can be given to all the babies. But this is something which we emphasize for the low birth weight babies. And this has the advantage of skin to skin contact with the mother. Even there are studies where kangaroo mother care is given by the father as well, and it will also promote breastfeeding because the baby is always with the mother. And also it also provides emotional support to the mother and the baby. And also it prevents the more intensive care to the baby, so that if the baby if it is a high risk baby, of course the intensive care is required. But if the baby is in kangaroo mother care, there are a lot of benefits that are seen, that the baby is gaining weight and the baby will get better feeding, and also it promotes optimal brain growth. So what is important here is that we need to educate the parents that how they have to be on this kangaroo mother care, how to put the baby, how to position the baby, and how they can have a good sling so that they can support the baby and that they can carry out the work routinely. So these are the things that they have to be educating. At the same time, mother has to be educated when she is having the baby in kangaroo mother care, that she needs to observe continuously the baby, especially breathing of the baby, the color of the baby. Suppose if there are any difficulties for the baby to feed, take breast milk. So these are the things that we have to educate. And sometimes the family members may not accept for initiation of kangaroo mother care. In that case, we need to educate the family members, and this especially happens because of the clothing. So we need to counsel the family member the advantages of kangaroo mother care, that what we have seen based on the evidence-based practices. Okay, so next slide, please. At the same time, suppose if any baby requires transportation to any newborn facility care. So while transporting the baby also, suppose if there are facilities of incubator is available, then it is fine. If such facilities are not available, then we need to see that the skin to skin contact that is to be maintained so that warmth for the baby is continuously maintained. Next slide, please. Another important aspect that we have to focus is feeding the newborn baby, especially these small for gestational age babies, that they may not be able to take the breastfeeding many a times. And in that case, we need to see what feeding that is preferable to those babies. Suppose a baby who is more than 34 weeks of gestation will be comfortably able to suck at the breast. So suppose if a baby who is less than 34 weeks of gestation, maybe at 28 weeks of gestation or less than 28 weeks of gestation, may not be able to suck at the breast. In that case, we need to assess the baby's ability to suck at the breast. And if the baby is not able to do that, we may have to choose any other options, whether it is spoon feeding, whether it is a palate feeding, or a baby who is less than 30 weeks of gestation may not be even able to swallow the milk which is given by spoon and the palate, because they have difficulty in coordination of sucking, swallowing and breathing, and baby may have to be given feeding through the orogastric tube. Or if it is very severely low birth weight babies, they may require feeding through the IV fluids that may be given. Here, feeding the baby, that is important because the baby has to get the nutrition. So these are the things that we need to educate the parents, that why the feeding is important, so that the baby gets at least whatever that routine. Normally what baby has to get at least some feeding that the baby gets, because many a times they will say baby is not taking feed, baby is not gaining weight. So we have to see the ability of the baby in sucking, swallowing and these things. And one important thing is that in evidence-based practices, we need to ensure, irrespective of the type of feeding that we give to the baby has to be put on breast, so that here baby's sucking can be improved when the baby is put on the breast. Can we have the next slide, please? So in conclusion, these are some of the things, though there may be a lot more things, even care of the cord and all that. Like there are a lot of studies which are carried out. Now the evidence-based practice for cord care is that dry cord care, so that we don't apply anything when it is a institutional care. There have been a lot of studies where breast milk is applied, or saline is applied, or a spirit is applied. So these are all a lot of studies which are not that practiced in many settings, but some studies are there. But the evidence-based practice is only for the dry cord care. But if the baby is in a home setting or any rural setting, so 1% chlorhexidine that can be recommended as a prophylactic use to prevent any chance of infection to the newborn baby. So in conclusion, that we have to see that the evidence-based practices in newborn care that has to be disseminated to all the people, because some of the studies what I have seen, it indicates that there is a low level of knowledge among the primary healthcare workers. And also knowing this, having this knowledge is not important, it is also use of these practices in our day-to-day practice is more important. So if we carry out these evidence-based practices, and especially when we talk about the newborn, as I mentioned, we do not require any high-tech facilities, all the simple measures that can promote the health of the newborn, which are cost-effective evidence-based practices. So with this, I conclude my session, and I thank all the organizers for giving this opportunity to me. Thank you. Over to you.
Thank you so much, Madam Dr. P. Sethi, Safi Sethi, for a wonderful presentation highlighting the new evidences on newborn care. We are delighted, and I believe that participants got benefited with that. We have a couple of questions here, and those questions are, I'll take up one by one.
Yeah, I think there is a box HIV
Yes,
positive mother breastfeed.
Yes,
the HIV positive mother also to be encouraged for breastfeeding, because there are advantages for the baby, the more advantages for the baby than for not breastfeeding the baby. So a baby mother and the baby may have to be under the ART treatment. So here syrup nevirapine to be given for a baby who is born to a HIV positive mother. Then the mother, while feeding the baby, to be encouraged to have continuous breastfeeding. Here a question comes whether the mother will be able to continuously feed the baby for 6 months or no, or during the period of ART, that period. So one of the important thing that we have to remember is that we have to educate the mother whether mother prefers to have continuously breastfeed the baby, or the mother can go for the replacement feed, because the replacement feed can be expensive for the mother if she has to buy all the time something to feed the baby. But during the treatment, this when they are in with the ART, there should not be mixed feed for the baby who is under with this treatment, baby of a HIV positive mother, because that may cause more viral load to the baby, as well as more chances of infection because of the mixed feed. So if the mother accepts to breastfeed, if her health condition is good, she has to have either breastfeed. If she is not able to feed, then during that time she has to go for the replacement feed. So that is the recommendation, that is evidence-based recommendation. Is that clear? The question is from Shilpa Sharma.
I think, ma'am, it has to be clear, and I hope it's clear. Now, next question is from the
Roja Rani. Yeah, preterm low birth weight neonate can be bathed after they gain weight of 2,500 till they gain 2,000. Bathing shall be avoided as per the preterm modules. Yeah, see, this preterm or low birth weight babies, if they are stable, generally stable, then it is okay. If they are not stable, unless they get adjusted to the extrauterine life, their birth is delayed up to 7 days. So when their weight is 2,500 grams, that doesn't mean that they are low birth weight babies. Okay, so there no question comes low birth weight baby. If the baby is low birth weight and they're not stable, then they are about to be delayed. That is what is the recommended practice. KMC can be given by mother, father, grandparents, and significant others. Yes, of course, we say kangaroo mother care, but recently there are so many studies where father also gives kangaroo mother care, and it has been proved that the kangaroo mother care has been effective even if it is provided by the father. So there are certain studies. So instead of bathing the preterm low birth weight, warm sponging can be given by taking care of the preterm dried immediately. Of course, the skin care in case of the newborn is very important. So sponging is not not bad, because otherwise the skin sometimes the skin will not be clean. So skin care in case of the newborn is of very important. So that can be done. Then KMC. What interval we can give birth to the newborn after birth if it is healthy and having good weight? See, in case of the normal newborns, it is usually recommended as per the evidence-based practices to delay the birth for 24 hours, because sometimes even if the baby's weight is good and the baby is healthy, externally we may not know is there something physiologically wrong. So recommended practices to wait for 24 hours. If it is not possible, at least for 6 hours, the baby bath has to be delayed. Can you explain few lines on finger feeding? Finger feeding, I think in case of newborn, we are not talking about the finger feeding on newborn. I do not know what is the doubt exactly that is asked here. Dr. Suresh?
Yes, ma'am.
Finger feeding, I do not know what exactly. For newborn?
She might be, explanation about finger feeding involving the baby, where breast milk or formula feed is giving via a fine feeding tube, and the child sucks on an adult finger, and then the tube is kept there, so the fluid is flowing, and then the child can suck over it. This is a technique, but still, it's not very popular one. This is primarily done for the babies who can't suck on a rigid breast, where the expressed breast milk is used, and the babies who have lost the mother, and rather than using the
No, here the thing is, the practice is that if the baby is not able to take the breastfeed, then the next preference that is given for the baby, if the baby is able to suck and swallow, the choice is palatal feed or the spoon feed. And especially the babies whose gestational weight is less than 34, maybe from 30 to 34 weeks, in that category, those babies may be able to suck and swallow when the feed is given. Expressed breast milk is given through spoon or palatal. If that is also not possible, suppose if the baby is having regurgitation, this vomiting, and not gaining weight, so in that case, that baby may be given the this tube feeding, not finger feeding, tube feeding. And maybe if not that also, then we can see for the intravenous fluid where the baby gets the nutrition. So there's no finger feeding. Maybe that is in case of a little bit older infants, may not be in case of a newborn. Because as much as possible, we need to avoid giving directly, other than breast milk to the newborn baby, because of chances of infection.
Ma'am, next question is Akanksha. She is saying, explain about providing KMC for preterm babies. So there is a new concept about IKMC and MNICU, MNC.
New concept about IKMC.
Yeah.
No, can someone tell about that? No.
Ma'am, it's an impact of continuous kangaroo mother care initiation.
Okay, okay.
Yeah. And IKMC is primarily used in for the newborn who are weighing less, that is 1 kg, and less than 1.8 kg. And there had been trials and they found that this IKMC is better than the KMC, the conventional KMC technique.
Okay, okay. Thank you.
Yeah. I think, ma'am, that's all about the questions. Thank you so much for wonderful presentation you have done. All three speakers. Now I hand over back to the organizing team to take up the next session or maybe having a small break. Thank you so much, Dr. Asa Piseti and all other two speakers of the session.
Thank you. Thank you,
Thank
sir.
you so much, Professor Suresh K. Sharma, sir, for holding this session along with the eminent speakers. And this was a very informative session. Thank you, sir. Thank you to all the speakers. The post link will be shared after the last plenary session. And now, let's take a 15-minute short break. And I request you all to join by 11:45 a.m. Thank you.
College of Nursing, AIMS Jodhpur, and Dr. Lekha Vishwanath, Professor, Swami Rama Himalayan University, Dehradun. Professor Raj Rani ma'am has more than 40 years of experience in the field of nursing education and administration. She also established College of Nursing, AIMS Jodhpur. She has many research articles and papers published in national and international journals. Madam has received International Achievers Awards for Education Excellence at Bangkok, Thailand, and ma'am has also received Rajiv Gandhi Award by Global Achiever Foundation, New Delhi, as well as Rashtriya Vidya Jyoti Award by Indian Society, Bharat Gaurav Award by Indian International Fellowship Society, New Delhi, and Rashtriya Shiksha Gaurav Puraskar by Center for Education, Growth and Research. And Madam has also contributed several chapters in many books.
The second chairperson is Dr. Lekha Vishwanath. She is Professor of Himalayan College of Nursing and Quality Manager at Swami Rama Himalayan University, Dehradun. Ma'am has total experience of 18 years, 16-year teaching experience plus 2-year clinical experience. Ma'am has 13-year experience at Amrita Institute of Medical Sciences, Amrita Vishwavidyapitham Health Science Campus, Kochi, Kerala. Ma'am has 2 years with Eternal University, Baru Sahib, Sirmaur, Himachal Pradesh. Ma'am has published 46 national and international papers and has guided more than 40 dissertations, and she has ongoing projects on development of a collaborative model for nursing with integration at different levels. Ma'am has several awards. Ma'am got distinction for pre-PhD examination. Ma'am was specialty topper for MSc Nursing, University of Calicut. Ma'am is also Editor-in-Chief, Journal of Nurse Midwifery and Maternal Health, Editorial Review Board member of 5 international journals. Ma'am is also a resource person and also invited speech for more than 25 conferences and workshops. Ma'am also leading the team for NABH and NAAACC assessment. Over to you, ma'am. Now, I would request our respected chairpersons to introduce our speakers for this session.
May I request Rajarani ma'am to introduce the first speaker? Should I? Yeah.
Ma'am, you are the co-host now. Please unmute yourself, Rajrani madam, and on the video. At the time,
Also,
uh,
can you do it for madam?
yes.
Now it's audible?
Yes, yes, ma'am. Yes, we can.
I have started the video.
Then we can hear you now, but we can't see you.
Now it's okay. Am I audible to all?
Yes, ma'am. You're audible. Please go ahead. Yeah.
Good wishes and greetings to everyone attending this wonderful academic feast organized by the AIMS Jodhpur on the virtual Midwifery Congress MidCon 2022. ICM Essential Competencies for Midwifery Practice, Indian Perspectives. This topic is a very, very important, and it is also important if we talk of our health indicators, because midwifery it include both mother and the child. And this here, mother and child, is very, very important when we're talking of the health indicator also. But here, a very, very important selective topic, that is the competencies for midwifery practice, Indian perspectives. You know, the midwifery practices, these are long established and have taken many turns, many improvements. So I think I would like to introduce the speaker. Kindly set the resume. Speaker, yes, Hemlata. So I welcome Hemlata, tutor, clinical instructor, College of Nursing, AIMS Jodhpur. I think you recruited in my absence. That's why I think you're new to me. So welcome in this college. As the education, she did MSc in OBG and experience, she has 5-year teaching experience in UG and PG level. She is also presently having 8 research publications to her credit, written many books, chapter also. Her additional achievements as the Merit Award in MSc Nursing, Obstetrical and Gynecological Nursing at Maharishi Markandeshwar Deems University, Ambala in 2018. Best Paper Presentation Award in International Nursing Conclave on Leading Nursing in Times of Change, Art, Science and Innovation, Jamia Hamdard, New Delhi, 2018. She presented e-poster at 12th World Congress on Industrial Health Care and Medical Tourism 2017. If we talk of scholarship from Army Welfare Education Society, AWES, for merit student during BSc Nursing at Army Institute of Nursing, Guwahati, 2009. So she is a very, forward-thinking young candidate. So I request her to present the topic.
Thank you so much, ma'am. It's my proud privilege to be introduced by you. Thank you so for the best wishes to join AIMS Jodhpur. I'm glad, and definitely I will also wanted to see you soon at AIMS Jodhpur whenever you visit us. Thank you so much for this, and it is a great pleasure for me to get an opportunity on this big platform to present the topic. So from my side, I would like to share my screen. Please give a few seconds to me. I hope my screen is visible to everyone and I'm audible.
Yes, you can proceed.
Okay. Thank you so much. So since yesterday we are talking about midwifery, and this is the time when we came to the fourth competency or subgroup which we are going to discuss. Is my slides are changing? Okay, fine. So we came to the fourth subgroup where the competencies which we are going to talk about is the ongoing care of women and newborn. Total 6 competencies are there, and few of the questions were also coming in the chat box, like how many competencies are there. So we have 4 subgroups and 31 competencies as a whole given by ICM. So I'll be talking about the first competency, that is provide postnatal care for the healthy women. So talking about postnatal period, so postnatal period begins as soon as the mother delivers the baby till the 6 month of postpartum period. Yes, in the books we have seen till 6 weeks of the postpartum, but research evidences has proved that there are 3 distinct phases, but these are continuous. The very first phase is initial acute phase, which begins from the 6 to 12 hours of postpartum period, where second phase is subacute phase, which begins from second week and ends by 6th week of the postpartum period. And the third one, that is again a continuous phase and very important phase, because at this time the mother used to get discharged from us and she is at home. So it is the responsibility of the obstetric and gynecological nurse or the midwife, but also the responsibility of community health nurses also to go for the home visit, community health worker to go for the home visit and meet the mothers at their delayed postpartum period. So the first topic is that postnatal assessment, very important assessment we examine in order to identify any complications. And this is the new phase for the mother. The mother is carrying the baby for 9 months, and now this is the transition phase where she is landing up into the motherhood phase. She's having so many questions: what's going on with my body, what is happening with me? So it is a crucial stage and very important. Ma'am has highlighted that IMR and MMR is the statistics which we need to drop it down since morning. Also we are talking about to decrease the infant mortality rate and maternal mortality rate. So this is the crucial phase where we need to assess the mother. So the competency says that we need to have a knowledge regarding the physiological changes. If we don't have the physiological changes knowledge, we could not be able to identify what is going on in not in an appropriate manner, like talking about uterine involution, onset of lactation, healing of pervaginal tissues. Also, a midwife should know about the discomforts of the postnatal period which the mother can face. Also, she should focus on the need of the mothers, supporting the topic that is a rest, support, and nutrition, which is required not only for her but also for the baby during her lactation. Very important and very point which we used to escape is that the psychological response to the mothering role. I am talking about the motherhood. This is the very important phase where the mother has to be taught regarding the psychological responses which she can go through and how we can support it related to infant and the family. So this competency want a midwife to have a skill and behavior to know, to review the history of pregnancy, labor and birth, conduct a focused physical exam, monitor blood loss and assess mood and feelings. Very important to monitor blood loss. We have seen the cases where the mother lands up into the postpartum hemorrhage. So it is very important to check for the lochia, to check the loss which is occurring to the cesarean mother or either the normal delivered mother. Next, the midwife should provide pain control strategies. We should not say it is normal, this much pain is bearable. No, if the mother is saying that I cannot bear the pain, we need to have a control strategies over that. Also, the midwife should provide information about the self-care, very important. Also, the important point is the information regarding safe sex and family planning method. We have seen that mothers are carrying 2 pregnancy, 3 pregnancy, and we need to teach them about the family planning methods. If they are not ready for the permanent solution, at least we can teach about the temporary methods to them, what are the benefits of them. So it is very important for a midwife in this competency to know about the family planning methods. After me, the session will be taken on the family planning methods also. They will be discussing in details regarding that. So everybody who is in the participants of this group also, and those who have joined, everybody know that the postpartum period, if we are remembering, is that by the this mnemonic that is called as a bubble he. I will shortly go into that. The B stands for breast. Very important to check for the 4S, that is size, shape, symmetry, and the secretion, rating or not. And if it is on the second and third day, the mother will be complaining of engorgement. So very important, the breast need to be checked for any mastitis, any pain if the mother is complaining. As so you come upon U, U stands for uterus. Very important to know what is the tone of the uterus, what is the fundal height. As in the beginning, I have told that it is very important to assess the fundal height of the uterus. It will let us know what the involution process is going normally, or the physiological process which has to be occur is going normal or not. The fundal height need to be measured very importantly. The third B, the B stands for bladder. So many times we are going to the area and we are simply saying aap theek ho ya nahi ho. The very important, we need to ask about the bladder. The mother has emptied the bladder, because if the mother has been delivered through episiotomy, so the mother can be saying this thing, and we have seen that mothers are saying that I am having a burning micturition while passing urine. I have a fear to even pass the urine. I feel like there can be an opening of the stitches can be occurred to me. So very important, we need to ask the mother the bladder is emptied or not. Then we will ask for the bowel. First day of the postpartum period, or the 0 day of the postpartum period, mother will be complaining of the constipation. So it is very important to teach them what are the diets should be taken so that the constipation can be relieved. Also, if it is not relieved for at least 24 hours, we need to take precautions for that. The next thing, L is stand for lochia. Lochia is a discharge which occur till fortnightly, and we need to see on the color of the lochia, either it is rubra, serosa, or alba. A midwife should aware about these 3 colors, and at what time or at what day these colors are appearing. We need to count the number of pads the mother is using it, what is the consistency, and what is the mother is having perineal pain while secreting. So the next E is the episiotomy. We need to check about if the mother is has been undergone through delivery through episiotomy. We need to check for the RETA scale, stands for redness, ecchymosis, edema, discharge, and approximation. I have seen that we have so many literature saying that these scales are the tool where we can identify that the gapping of the episiotomy is occurring, infection presence is there not. So as a midwife, I will focus on this, that we need to use these interventions or this evidence-based practices which are available. So I always emphasize to check for the RETA scale, where we will get to know that episiotomy is in the healing process or not. H stands for Homan sign, the thrombophlebitis, we will be checking it. Previously, we used to have, I think everybody has been gone through their BSc time and the MSc time, the theory how we will check the Homan sign. The new evidence has shown that instead of identify for the click sign sound better, we will measure the calf muscles, and if there is a 2 centimeter and above difference between the 2 calf muscles, there is a sign or risk of getting thrombophlebitis. Last E, that is emotional response. stressing upon this emotional response, very important, how the mother is making this bond, because this is now parent-child bond which is occurring in this phase. So many times the mothers, even after having the babies, their moods are not appropriate, and studies has shown that most of the mothers, they are land up either into the mild depression or either in the psychosis, depending upon the situations. So in the coming slides, I'll be focusing on this emotional response too. So this is what we do in the maternal assessment bubble. Here you can remember this, as per that you can assess it. The next topic is that a postnatal care. You can see on the image how the mother is seems to be anxious. She is thinking about what is going on with her. The postpartum bleeding is going on. She is having a section scar is there, or either the episiotomy scar is there. She is undergoing mood swing. My baby is there. The bond she has to prepare. The breast is engorged, or either the breast milk is not coming. Lots of thoughts she has been undergoing. Also, she is not able to sleep, and she is complaining of night sweats, and somewhere the baby is kept far away, and she is thinking about it, how I will care about the baby. So these different changes has been occurred to the mother, which sometimes get neglected. So the important question is this postnatal care is really important? Yes, WHO has said that more than 3 in 10 women and babies do not currently receive postnatal care in the first day after birth. This is a big number which we are getting it. And they have suggested that the midwife should contact in the postnatal period, recommended at 48 hours, 72 hours of postpartum period, then after between 7 to 14 days, and the last one is during the week 6 after birth. So this is very important, that a midwife should not stop looking after the mother once she is discharged. We need to talk about, ask about, is there any ASHA workers nearby to their home? Is there anyone who can take care of them? If any complication is occurring, these are the things which can be occurring. Who will bring them to the hospital? So the key demands of postnatal care, which is published by WHO, Postpartum Care of Mother and Newborn, a practical guide. They have suggested that these are the needs of the baby and the mother. I will look upon to the mother between 6 to 12 hours. The blood loss need to be checked, pain to be asked. We need to check the PP, advices to be given regarding the warning signs of the heavy bleedings. 3 to 6 days, breast care need to be provided, because on the third day, the mother will be complaining of the breast engorgement, which is a very important point which we need to monitor. Temperature, infection, there can be a rise in the temperature due to the infection or the mastitis. How the mother is feeling to us in 3rd to 6th day. As per the WHO, they say that 6 weeks, the mother should be seen about the recovery of anemia. Yes, the mother has been losing the blood. So there can be chances that already we have seen in the Indian scenario, the mother are having a less hemogram. So in that cases, we need to focus on the anemia. Anemia is correcting or not? Is the mother is lands up into the severe anemia or not? Also, we need to teach about the contraception, because if the mother is not ready also, then also we can teach about the benefits of that. We can motivate the mother to go for the contraception. And at the 6th month, as I was focusing also, that after 6 weeks, our work is not ending. We have to take care till the 6th month. So we need to focus on the general health of the mother, how she has regained her pre-pregnancy weight, she has regained her pre-pregnancy physiological changes. Contraception we need to teach. Also, we need to teach about there can be a morbidity which can be occurring during this phase also, and how she can look upon it. So with this WHO cue cards and the pamphlets which are available, I would request everyone, we need to help the mother to adjust to the life with a new baby, which is very challenging. The low mood and anxiety can be normal to the mother, but it is very important to assess it in order to identify any deviation. We need to reach out. We need to teach the mother that reach out to the healthcare providers if you're feeling something is not going on the way. Caring for the baby, we need to teach her about that, how she can identify the baby's signal, how she can feel secure and safe with the baby, how she can provide the exclusive breastfeeding. how she can go for the baby vaccinated. So it is very important, once the mother is discharged, we need to provide Mamta card or the mother and baby child card, so that they can talk, see that what is the next dose of the vaccination, when to come, and we have to teach them like according to the Mamta card how they will be reaching out to the healthcare workers. Very important, the mother has to be taught regarding the development changes which is occurring in the baby, and the looking her own health is also very important, because she has to take care of the baby. So the first week following childbirth is a very important and special time. So all women and babies should receive the care after 24 hours of the birth. Also, we need to be in the contact with the mother till 6 weeks. Tell the mother to visit after 2 weeks and then at the 6th week, so that we can identify any changes which is occurring. Very important, yesterday we were talking about respectful maternity care. So while you are giving a care to the mother, we need to be respectable. Also, we need to respect the mother. Talking about listening her with the empathy. Simply don't say, "Ha ha, main sun rahi hu." No, and be empathize with the mother, what she wants to say. So many times we have seen the mother are feeling anxious and they were not able to even speak up what is happening with them and with the baby. So we need to build the confidence. We need to respond to the need of the women, babies, as well as the family. Maintain dignity, privacy, and confidentiality. Enabling informed choices. Do not always force your choices. It's mother choices who has to take it. So always provide with the informed choices to the mother. Ensure freedom from any harm or mistreatment. So many times mother are not even telling it what is happening with them. Be approachable to them. Be open to them. Provide empathized nature so that they will open up to you. Moving toward the next slide, and very important, I was talking about in the postnatal assessment is bubbler. So in that cases, the very first is breast care. All the mothers should be provided with a breast care, because it is physiologically, we have seen that on the third day, the mother is complaining of the breast engorgement. Studies have shown that the use of the cabbage leaf for the breast engorgement reduce the mastitis as well as the reduce the engorgement. So 90% of the primary parents mothers, they are complaining on the second and fourth day. So it is very important to use the evidence-based research evidences which are available. A study is published in year 2021 where they were showing the effect of cabbage leaves compared on the breast engorgement in the postpartum period. And the results were saying that using the cabbage compression reduces the engorgement among the mothers, and it's for the significant in nature. Thing is the peritoneal care, very important about the lochia. The lochia is discharges which is occurring, and at this time period mother is susceptible to get infections. So if the episiotomy is there or not, then also we need to teach her how to do the perineal care. Till the time mother is in the hospital, it is the duty of a midwife as well as a clinical instructor or a tutor or a teacher. We need to emphasize the students that what is the need of the perineal care and how we need to give the perineal care, because it does not only involve the washing the genital or a rectum. We need to focus on what are the other parameters which are changing, because the perineal care will prevent infection and odor. So the research evidences has been shown that we have lots of data which is available on the perineal care, but implementing this evidence-based practice in the perineal pain management in the postpartum. So this is the article which is published, which shows that the results is that there was an by improving the nursing care, results in the this is one of the best scientific evidence which is reducing the perineal pain also. One of our yesterday also we have seen one paper presentation where they are talking about the perineal massage and the perineal care. It is very important part and very crucial point also that we need to provide a perineal care to all the mothers. The third point is the diet and nutrition. I am focusing on that. In the beginning also, that nutrition of mother is not only important, now she has to feed also. So for the preparation of the lactation, the women should increase their intake, and at least it is recommended 2230 kilocalories per day to be taken by the mother. And very important, when we go to the area and we ask the mother, "Aaj aapne subah kya khaya?" They usually answer it like chai biscuit. I don't think so this chai biscuit or the simple biscuit and the tea would be able to provide the nutrition. So we need to give, not only educate, ye nahi khana hai, this cheese should not be taken, this should not be taken. We also focus on what else she can take, what are the habits. Also, while recommending any of the diet, talk about their traditional practices, because in Indian culture we respect the different diversity of the culture, and in some of the places they used to give jeera water in order to go for the normal involution of the reproductive organ. So respecting their cultural diversity, we need to teach them about the nutrition and the diet to be taken in the postpartum period. The research evidences has shown that one of the studies published that maternal nutrition intervention and maternal complication in 4 districts of Bangladesh. This study has been taken from the Bangladesh. Indian studies are also available. So they shows that maternal nutrition intervention providing intensive counseling and micronutrients. If we provide the nutrition to the mother, the micronutrient supplements even are not required artificially, which we are giving it. So we need to emphasize on that, the ability of the mother to increase her diet as well as to have a balanced diet. The next important part, always we are teaching to the students in the lab also, that is the postnatal exercise. But I want to ask how many time we go and really teach the mother. So it is the duty of a clinical instructor and as well as the teacher who is accompanying the students. Please focus on this point also, that is a postnatal exercise, not on the, at least not in the hospital. If she can do, at least we can teach at the time of the discharge the exercise to be performed, the light exercise which can be, say in the picture you can see the 4-point kneeling exercise. We can show that is a leg raise, leg slides, knee raise, leg extension. According to American College of Obstetrics and the Gynecology highlighted the benefits of the postnatal exercise. They say that exercises strengthen and tone abdominal muscles, they boost energy and relieve stress. It also helps in preventing the postpartum depression. It also promote better sleep. And if you remember the slide which I have shown, that mother is going from through different phases. I think the better sleep is required to the mother to take after, a rest after the lots of exhaustion which has been occurring during the 14 hours of the labor. It can help also mother to even lose, shed out the weight which is extra and which is gained during pregnancy. So this is a very important point. The research evidences has shown that postnatal exercise interventions, a systematic review of adherence and effective. They show that the agreement for the effect between the studies evident for the physical activity improve the physical fitness as well as it reduce the fatigue. Never ever think that if we are teaching the mother regarding the exercise, they will get fatigue. No, we need to teach her simple breathing exercises, simple leg raises, as which she will not feel fatigued. So only few sides are left, and with this picture you can see that mother is taking a feedback from the mother before discharge. She is asking, if the baby feels cold, what should you do? And the mother is responding that I will put it next to my skin and wrap it well. So here she is showing the positive feedback that she has understood. If the baby is having hypothermia, how she is responding. So it is very important that not there. Now I am a mother. Now motherhood has started, so I need to care. I cannot show that's the Edinburgh scale which we need to postnatal mother's depression, shown that the mothers are landing up into the postpartum blues type as in the postpartum psychosis. The mother are going through the phases, taking phases, and if they are not able to respond to this three new normal phases, they can either end up into depression or this. So the research evidence is so many research evidences available. One of the study that is a need disease. Also, one more study, that is the psychiatric disorders in the postpartum period, has been analyzed, and they are saying that if we are not treating a psychiatric disorder in the postpartum period, there can be a short or long-term consequences, not only to the mother but also to the infant. And we all, I think in every family we have seen that our elders used to say, जैसा आप बच्चे को समझाओगे या उनके साथ प्यार करोगे, then only they will be having inherited. So it is very important to always give talk about their mood, and midwife should ensure that mother depression is to be assessed by the EPDS. So, and a few other studies are also available. That a meta-synthesis of the qualitative study was done, and this was published on in the year 2020. And these studies affirm that a positive postnatal experience can result in joy, self-confidence, and enhanced capacity to thrive both as a person and a parent. It does not mean that only the mother will be having a pain in the postnatal period. Yes, studies has shown that the mother can even feel at a joy, because this is her new motherhood and they are already prepared through the 9 months. So midwife should teach about it, that after 9 months there will be a baby. You should feel positive, be positive, don't think about anything. If anything is coming to you, please open to us. So we need to be vocal about the potential changes which are occurring, and we need to help the mothers to adjust to this new normal following the childbirth. So with this things, I came to the end, and I always emphasize on research evidence practices to be used. So these are the validated tool which you can use, that is available on internet, that latch on scale for assessing the baby's attachment is there or not. Also the breast engorgement scale need to be applied before assessing the breast of the mother. In the postnatal period, Edinburgh postnatal depression scale to be identified for all the mother. Either they are landing up into the depression or not, we need to assess this. And the third one is that while they are having episiotomy, we go for the RIDA scale. So with this 4 is whole, I will focus on the take home message, and I don't want you all to take everything from this presentation. Only you can focus on these 4 things. Support the breastfeeding. Yes, the baby needs it. We need to focus on this health indicator. Provide a personal hygiene to the mother so that she will feel comfortable. Then only she will make the baby to be comfortable. Focus on her diet, what type of diet she has to take, and how she can meet the micronutrients. And the last one is mental health. Provide them a environment to have a good bonding with each other. With this, these are my further readings. If you have any query, you can put up in the chat box. And with this, I came to my end of the presentation. Thank you. Ma'am.
Ma'am, please unmute, ma'am. Ma'am, please unmute.
Devika, it was really an excellent presentation. You covered all the topics and really appreciate the passion with which you are presenting. So that was
Thank you
reflected
so much,
throughout.
ma'am.
So I really appreciate. I think ma'am could not unmute herself. Radharani ma'am. I think we have few questions, sir. First question I would tell is, if mother undergone normal delivery or cesarean section, when to emphasize or start with the postnatal exercise? It's a question from Neha Permar.
Okay, thank you for the question. And it is very important part when we are talking about the postnatal exercises. Yes, as soon as you can teach about the breathing exercise, second off, the postnatal period. Either it is a cesarean section or the normal delivery. If the mother cannot able to bear it in the cesarean section, we can teach on the third day. You can talk and you can able to answer the question.
Yeah, you have answered it. So gradually we can introduce the exercise as the client tolerates it. Right. The next question is, during the lactation amenorrhea, any chance of getting pregnant? Which contraception will be best?
Okay, fine. Thank you for another question. Yes, we have seen the cases, the mother are coming and they are and throwing the light on this special topic. I think Madam Arti will be in her presentation. She will be the best person to answer on this.
Sure,
Madam
yeah.
Lekha, more light on this, I will be happy.
So one more question. Is in postnatal period, is it okay to use tampons or tampons and menstrual cups?
In the post, when the lochia is occurring, we do not recommend, and we have not. Personally, I am very interested to even the uses of the evidence to use the resultant regarding this usage. It can cause the mother a discomfort.
Yeah, sure. During postnatal period, it can cause discomfort. And also we know the perineal vagina is lax during this period. It may be difficult to hold also the menstrual cups. It's better to avoid these two in the immediate postnatal period.
Yes.
Not immediate, in the postnatal period.
Yes.
I think that's all. I think we have finished question.
Thank
Ma'am, would you like to comment?
Thank you, ma'am.
Ma'am, you are still mute.
Is it okay now?
Yes, ma'am.
I would like to say that when we're going in the field and the mother should be taught regarding the breastfeeding, their concept should be very clear about the quality and content of the milk. They may not be knowing in terms of protein, carbohydrate, and vitamin, and this and that, but they must know what is the difference between hind milk and fore milk.
Yes.
Because sometimes the mother, they keep on feeding the baby only for the fore milk, and baby never reaches the hind milk. So this is one of the for the baby get weak and ras milk and all these things, because there are a lot of vitamin minerals and in the hind milk. Am I clear?
Yes, ma'am. Ma'am, we have one session coming up exclusively on breastfeeding.
Okay. Thank you.
Shall we move to the next?
Yes, ma'am. Even I support on available. Is I'm audible? Okay, thank you.
Yes.
Overall, it was a wonderful session.
Yes.
Thank you, ma'am.
Next speaker, she's Geeta Bhardwaj, Assistant Professor, Nursing College, AIIMS, Bhopal. I welcome you on this dais, and for her introduction, she is graduated from the Lakshmibai Batra College of Nursing in the year 2009, post-graduated from the Bharati Vidyapeeth College of Nursing in the year 2012, currently pursuing PhD from INC. Her experience contribute 1 year clinical experience and 9 years of the teaching experience. Regarding the research publication, in various index, she has a publication in the index national and the international journals, and area of research interest is twin breastfeeding and the maternal health, very important areas. And she got the award and achievement as she has completed NPTEL research courses, operational research, food flexology, and the lifetime member of the various national organization and the association working for maternal and the newborn health, such as BPNI, NNF, IANN, ALPI, SOMI, GNI, NRSI. So, biodata. Geeta Bhardwaj, you come on the dais.
Thank you so much, ma'am. Thank you so much, ma'am. Am I audible?
Yes.
Yes, you're audible.
Thank you so much, ma'am. It's my honor to be introduced by the eminent personality, Professor Dr. Rajrani, ma'am. A very warm good afternoon to the organizers of Team AIMS Jodhpur, faculties from other institutions, and the attendees of this virtual Midwifery Congress. I thank Team AIMS Jodhpur and special thanks to Professor Suresh Sharma sir for giving me this opportunity to deliberate on the important topic, that is detection and management of postnatal complications. Let me share the screen. Please let me know if it is visible to all.
Yeah, it's visible.
Visible, ma'am? Thank you, ma'am. Coming to the topic, my topic that is given to me is detection and treatment of postnatal complications. I'll be just giving a brief about the background of maternal mortality, a brief about the postnatal phase, major postnatal complications, risk factors of postnatal complications, identifying the postnatal complications, and management of major postnatal complications. Though there are various postnatal complications that are life-threatening, but there are other postnatal complications that may have an impact on the quality of life of our postnatal mothers. So here we'll be just focusing on the main points, and we are very, as you can say, as we can see here, it is generally thought that journey of a mother, the pregnancy usually ends up with the delivery of a healthy baby. Yet the mother's health after delivery is equally important as the health of a newborn. We generally focus on the health of a baby. Yes, now the delivery has happened and now everyone is happy, and we are neglecting the maternal health. So that is ultimately leading to the complications into the maternal health. So here, a very recent study has been published in March 2020, where I'll just use my pointer here. Recent trends in the maternal mortality that is published in 2022 March, where they have highlighted like there is a huge decrease in the maternal mortality, that is from 400 till now at present it is 103 current maternal mortality per 1 lakh live birth. So again, though we have reached like around 103, but still, if we are talking about the Indian perspective, in some states like UP, MP, where you can see still the MMR is very high, and if we are comparing the other states like Andhra Pradesh, Kerala, the maternal mortality has achieved the, it is as per the SDG target that is been set by 2030 that we will achieve the MMR by 70. So they have already achieved. So this is a good point that we can say here. So now here, when we're talking about the maternal mortality, so what are the major reasons like why it is occurring? WHO says like there are 3,03,000 maternal deaths annually, and these deaths are mostly occurring into the postnatal period and compared to the intranatal and the antenatal period. I think this number is very huge. So when we are talking about the Indian perspective, what are the causes? Why there are deaths in the maternal health? Because in the maternal, so the major deaths they are because of the hemorrhage. We all have already known like hemorrhage is a very important cause of the maternal mortality. And after hemorrhage, there again comes the sepsis. Sepsis, it can be the prepubertal sepsis, the sepsis after the abortion. All these can lead to the maternal mortality. They are the major causes where we can just have a look how we have to identify and how we can correct this thing so that we can save the lives of the mother. So where is the problem? Why there is a high number of maternal mortality? There is delay in identification and management that is increasing the morbidity and mortality. Delay in identification. We, as I already told, like we are neglecting the maternal health. Now baby has delivered, everyone is happy in that way. So we delay in the identification. Ki yes, what are the vital signs, how the mother is feeling and all this thing. Then there is delay in the decision making. We are not able to decide whether what we have to do now. So that is the delay, whether we have to refer the mother, whether we have to keep her just for the observation and all. Then there is delay in reaching the facility. Like though our country where we have the most of the population, the rural areas where the mother they come to the PHC, CHC for the delivery purpose. So if we don't have the proper facility to refer the patient, then it is again a major cause of maternal mortality. Then delay in providing the emergency care. So we know like we have to shift the mother, but by the time what emergency care we can provide to the patient, that is also not given, like resuscitation, at least maintaining the IV fluid of that mother. So these things are very important. Now for this topic, actually Hemlata ma'am very well defined about the postnatal phase. So I'll also just highlight the postnatal phase. It starts immediately after the third stage of labor till 6 weeks after delivery. And the important phases are immediate one. Immediate, that is within 24 hours of delivery. WHO says this is the most crucial phase where there are findings like 66% of the majority of postnatal death, they occur within 24 hours. And early phases, that starts from the second day till the 7 days, and remote phase up to 6 weeks. So these are the phases where the mother is not in the hospital. Generally, she is discharged from the hospital and she goes at her home, where is the actual role of the rural healthcare worker starts. As the government says, like they have to visit the mothers, they have to have a proper follow-up, they have to identify, so that we can tackle and we can identify the postnatal complications that are occurring at the in these phases, early or the remote phases. Now, if we say when you're talking about the identification of the complications, how we will identify that mother is having the complication, it must start with the identification of the risk factor. We cannot deny this fact, like the mother who are at risk, they are more prone to the postnatal complications. So here some of the risk factors of postnatal complications are like precipitate or prolonged first stage and second stage of labor, overstretching of the uterus, birth traumas, history of postpartum hemorrhage, uterine rupture or uterine surgeries, past placenta accreta, increta or percreta, current diagnosis of the placenta previa, uterine fibroids, coagulation disorders, maternal exhaustion, malnutrition, grand multiparity, uterine infections, and there are like many more. If like PRM has happened, chorioamnionitis is there, or even the mother has underwent the cesarean section, that is also very important risk factor where we have to look at. Because see, we all know, like if the mother has underwent the cesarean section, we have to very carefully observe the signs of the infection. Cesarean section is one of the very important thing where the mother is more prone for the these kind of infections. Now, as Madam Hemlata has already told about the bubble assessment, why I'm emphasizing here about the bubble assessment is, as we said, like for the management of postnatal complications, first we need to identify what are these postnatal complications. So for these we need to identify, and how we will identify. First, as the delivery happens, we have to be observant, we have to be vigilant, and if like everything is going well with the mother, we have to thoroughly see the mother. We have to assess her by Babalhi method. There is like breast, we have to see is there any issues with the breast, her uterus, involution process, fundal height, lochia we have to see. Then bladder issues we see, bowel we have to see, lochia, episiotomy, Reader scale. Very clearly she has explained about all these things, human signs and the emotional status. If we are able to identify yes, everything is going normal, and if there is anything abnormal that we are detecting, yes, these are the abnormalities, so we can further see the sign and the symptoms, and we can further ask for some investigation so that we can confirm yes, these are the complications which are occurring to the mother. So the first thing is the proper assessment of a mother regularly when she is in hospital, and even when she is discharged at the community level. The community healthcare workers and ANM ASHA workers, they have to have a proper follow-up and look for all the signs and symptoms. So now coming to the postnatal complications, what are these postnatal complications? There are postnatal complications which are very life-threatening, that are contributing to the maternal mortality. There are other postnatal complications which are not as life-threatening, but still they are they are decreasing the quality of life of a woman. Like if we are saying she is having constipation, she is having incontinence after delivery, so they are the complications, but they are affecting her life. We cannot neglect those complications, but we generally focus on the complications that are leading to the mortality. So as I already told, postpartum hemorrhage is the main cause, then puerperal sepsis, subinvolution, mastitis, venous thrombosis, amniotic fluid embolism, pulmonary embolism, DIC, uterine inversion, urinary and bowel complications, and the most neglected one that we say, yes, every woman will be happy after delivery. No, this doesn't happen. They still have the psychological disorders. So all these things we have to see. Now coming to the postpartum hemorrhage, the major complications that occur in this. What is postpartum hemorrhage? We all know when there is a loss of blood that is more than 5 ml after the normal vaginal delivery, and there is loss of 1000 ml if the cesarean has happened. So, and there are types of PPH, that is primary PPH and secondary PPH. In primary, the majority of the mortality occurs, and that primary occurs within 24 hours after delivery. And this is the time where the mother is there still in the hospital setting, where we can have a prompt action, we can manage and save the life of a mother. Then there is secondary PPH. We cannot say we have discharged the mother, now she'll be okay. No, there are chances like when she's at home, even then she can have the bleeding and secondary PPH. That also we have to see. My slides are not moving. Yes. Give me a second. Yes. Now, identifying the PPH, how do we have to identify that this mother is going into the PPH? First is, again, as I said, the risk factor, we have to see PPH. If the mother is having a case of PIH, if the mother is having a case of anemia during antenatal mother, we have to be very observant, like she may undergo the PPH. So it's not like complications, they have to be they have to be taken care in the postnatal phase, not like that. We have to be very thorough about her antenatal phase and the intranatal phase, how it happened. Then we have to assess for the blood loss, how much is the blood loss. Then after that, we have to monitor the vital signs. That is very important. Within 5 minutes, WHO has given the guidelines, like within 15 minutes, we have to see, within within 2 hours, 4 hours, we have to see the vital signs. Then we have to observe what is the pulse. Is it 110 beats per minute or more than that? Is it weak or fast? BP systolic, it should not be less than 90 mm of Hg. Respiration rate, that should not be more than 30 beats breaths per minute. We have to look for the signs of shock also. Cold or clammy. Then we have to check for the level of consciousness, whether she is conscious or she is going to unconsciousness.
अच्छा या तो वो मुझे लिख के दे दो क्योंकि आपने इतना लेट बताया ना आई कांट फॉर्म
Excuse me, ma'am.
ताकि मैं उसे रीड आउट
Okay, then after identifying all these things, what we have to do? See, these complications are the emergency situations where a single person cannot handle all these things. So we have to shout for help. We have to mobilize all the healthcare persons which are around us. Even the student nurse also can be involved for these procedures. Then we have to resuscitate before doing anything. At least we can, if we are thinking about the saving of the life, then we have to resuscitate the mother. For resuscitation, at least we have to maintain the IV line. We have to withdraw the samples. We have to start with the normal saline or RL, then O2 administration immediate, then oxytocin 20 unit, that is to be given into the 500 ml RL at the rate of 40 to 60 drops per minute. Then it is positioning head and can be low, then keep the mother warm, and at least catheterize the patient. These are the basic thing at least any midwife can do to save the mother. Then we have to arrest the bleeding immediately, like misoprostol is given. We have seen in our clinical settings these tablets are given. And then immediately uterine massage. Our hand just goes on the uterus of the mother. We keep on massaging by manual compressions. Then again we have to monitor the vital signs every 15 minutes, and we have to look for the blood loss. These were the main basic steps. After that, we have to identify what are the causes. What is the cause of PPH? Then according to the cause, we have to treat the PPH. So majority of the causes we all know, like there are 4 T's we all have read in our theory parts. The majority of the causes causes atonic uterus. When the uterus is not contracting, it feels soft and boggy. And other causes are like tissue, when the placenta is not yet delivered. Then another cause is trauma. If there is any trauma to the cervix, or is there any uterine inversion, or like in rare condition there could be thrombin disorder or like coagulation disorders. But mainly we have to focus on the atonic. If the case is of atonic uterus, then what we have to do in this case, we have to massage the uterus. And then we have to administer 10 unit IM, then 10 unit IV, and bimanual compression, Buckley balloon method, and artery pressures. These are some of the options which can be done to manage the case if there is atonic uterus. When we are talking about the tissue, if tissue is a reason, like placenta has not delivered, so what we have to do? There is continuous bleeding. So in that case, we are impulsive to deliver the baby, deliver the placenta, but for this, the women has to undergo this UHG. We have to rule out whether there is any placenta accreta, percreta or not, because in that situation we cannot manually remove the placenta. This will have a more bleeding. So in that we have to ensure whether these situation is not, if that is not there, no placenta accreta is there, then we have to manually remove the placenta. Then coming to the trauma part, what we have to do here, we have to clamp the part where there is a tear, and the inverted uterus can be replaced, and all these patients can be further referred to the higher centers. Similarly, in the case of coagulation disorders, there could be administration of the blood components, and then the patient can be referred to the higher centers. So this was the basic, this was the management that we have to do to prevent the, to manage the PPH. Our systematic review has focused, like I said, in the management of atonic uterus, we have to give the Buckley balloon method, but Buckley balloon seems to be less effective tool for management of PPH nowadays. So our systematic review is supporting that one. Then these are the pictures like which are showing how the bimanual compression is done, Buckley balloon, how it works. It pushes the uterine endometrium layer of the uterus and the aortic compressions. So now coming to the puerperal sepsis, again, this is a preventable one. I must say this is a preventable one where we being a midwife, we can prevent these puerperal sepsis right from the if we are working on the antenatal phase, intranatal phase, we can at a very high level, we can prevent this puerperal sepsis. So what is puerperal sepsis? It is an infection of genital tract, and it occurs between the onset of rupture of membrane or labor and till the 42 day of the postpartum, like 6 weeks of the postpartum. So how we will determine if mother is having puerperal sepsis, having any two symptoms or signs. One is pelvic pain if she reports a pelvic pain. If she is having fever more than 101.3 Fahrenheit, then if there is purulent or abnormal vaginal discharge, abnormal smell or foul odor of the discharge, then if there is delay in the rate of reduction, as we during our postnatal phase, we keep on assessing the fundal height. If there is no reduction of the uterine size, so there we can assess, we can say yes, she may be having the puerperal sepsis. So how we will actually detect she is having this puerperal sepsis or not? One is by history. What was the mode of delivery? Was it cesarean? Was it normal? Was there any rupture of membrane? We have to obtain all that history. We have to see the general, we have to do the general examination. We also have to have the inspection of the external genitalia and the perineum. As I said, mothers are generally discharged after 2 days or 3 days after delivery. So puerperal sepsis are the cases which may occur in the late phase also, when the mother is in home. So when she is coming to the hospital, we have to see all these things, inspections and all, then assess the size of uterus. So after doing all this, we'll be able to see if there is any rise in the temperature or pulse rate. That is again an indication of sepsis. Then offensive or copious lochia, chills or rigor. Then is there any rapid pulse? Is the lochia, is it scanty or odorless? Then uterus may be subinvoluted, tender or softer, or the general condition is she's having generalized malaise. So by this we can identify that yes, she is having puerperal sepsis. After these, we can also go for the investigations like complete blood count, where WBCs can be seen. There will be rise in that. Then blood urea electrolyte level. High vaginal and endocervical swab for the culture sensitivity, urine for culture sensitivity, pelvic ultrasound. Because see, these sepsis are the thing, if they are not taken care of properly, they can again have a severity. There could be endometritis and all this thing. Then CT and MRI and chest X-ray can be done to identify the sepsis and its severity. Now coming to the management, how we will manage if the mother is having puerperal sepsis. Again, the basic thing is adequate rest can be provided to the mother, maintenance of the hydration. By IV fluid therapy, patient will be admitted to the hospital. Then analgesia can be administered for the pain if she's having pelvic pain. Catheterization to remove any urinary retention if there is. Then monitoring of the vital signs, intake output chart is maintained. Antimicrobial therapy as prescribed by the doctors, like in clindamycin, ampicillin, cefotaxime, all these things, metronidazole, very important, that can be given for the management of this puerperal sepsis. Now, WHO says as during COVID, we have seen the hand hygiene, all these things. So these there are 5 moments of hand hygiene that we can practice even in the maternity unit, and these are very important to reduce the rate of puerperal sepsis. One is before touching the women and the newborn. Another one is before clean aseptic procedures. After body fluid exposures, we have to clean our hand. After touching the women and the newborn, we have to clean, and then after touching the women, newborns surrounding. These are the 5 points where we can maintain the hand hygiene. Now coming to the subinvolution. In continuation of puerperal sepsis, the mother may develop the subinvolution. Or then in this, it is generally asymptomatic. Abnormal lochia discharge happens in this. Irregular or excessive uterine bleeding happens in this condition. Irregular cramp-like pain in case there is retained products of placenta or there is rise in temperature. So how we will detect that she is having subinvolution? In this, again, the very important thing is, as Madam Hemlata has already discussed about the assessment of the uterus. In uterus uterine assessment, we have to see the height. We have to see the position of the uterus and the tone of the uterus. So in case of subinvolution, what happens? The uterine height is greater than the normal. We are expecting a low uterine height, low fundal height, but it is not that, it is greater than the normal one. The uterus feels boggy and the softer one, and this is displaced. So what is the management for subinvolution? Again, as this is because of the infections and all, so antibiotic will be given, and then again the exploration of the uterus can be done. Sometimes it happens like there are retained parts of the placenta, so that can be removed and we can manage the case. Now coming to the another postnatal complication, that is puerperal venous thrombosis. we know like there is a rise in the case of cesarean sections. We have seen mothers, they are after cesarean section, they are like 24 hours, they are not mobilizing, they are not moving their legs. So there are chances of thrombosis that can complicate the postnatal phase. So some of the disorders are deep vein thrombosis, thrombophlebitis, and pulmonary embolism. How we will detect the DVT? Again by Homan sign as it comes into the bubble E. So lower extremities we can see for the presence of hot, redness, painful and nodular edematous areas. By this we can see ki yes, she is having positive Homan sign and it could be DVT, and the elevated temperature. Now, how we will manage the DVT? Here in this, the basic management is patient is placed onto the bed with foot and raised above the heart level, and pain on affected area is treated with the analgesics. Antibiotics will be given, and administration of anticoagulants will be given for the thrombosis, and low molecular weight heparin as mother may be breastfeeding. So in that case, these are the things which we can do to manage the DVT. Now, if we are talking about the embolism, again, pulmonary embolism, it is in this condition there is sudden collapse with the acute chest pain and air hunger. Death usually occur within short time from the shock. And in this, how we can identify she is having pulmonary embolism is suddenly if the mother is having tachypnea, dyspnea, cough, oxygen saturation is less than 95%, tachycardia, rise in temperature, hemoptysis. So these are some of the signs that we can observe for the pulmonary embolism. Again, how this will be managed? See, as I said, this is a very emergency case where there is sudden death can happen in this. So we need to resuscitate the mother. Again, oxygen therapy, IV is started. Then heparin therapy is given to the mother. Heparin level is maintained from 0.2 to 0.4 unit per ml. IV fluid is supported. BP is maintained by dopamine, and thrombolytic therapy is given, streptokinase. So this is the management that we can do for the pulmonary embolism. Now coming to the another very important, as Madam had Professor Rajani Ma'am has also focused on the breast issues that occur during the this postnatal phase that are mostly neglected. Mother will be able to feed, it's okay, she'll feed the baby, and we are less focused on the breastfeeding thing. But if we are not focusing on the early initiation of breastfeeding, what will happen? Suddenly, like eventually all this thing will develop. Breast engorgement will develop. After, if breast engorgement is not treated well, mastitis will develop. Subsequent to mastitis, breast abscess will happen. Then she will have the chronic breast pain. She will have candida infections and painful nipple because of crackness and all this thing. So these are the various complications that can occur due to in the breast, and ultimately will affect the breastfeeding of the newborn. So these are the, like here we can see engorgement, how does it look like? So being a nurse, being a midwife, we should be able to assess, see, yes, these are the symptoms of breast complications. In mastitis, it will be very, there will be a high rise in temperature and all this thing, redness will be there. So again, how as management of breast engorgement, Madam has already told, Hemlata Ma'am, that there could be there can be application of the cold cabbage leaves, so in that way we can manage. But the major thing is, like in case of mastitis, how it will be done. Again, here what is the problem where the mother thinks, or the like nurses, what they do here is they ask sometimes mother, you don't breastfeed because you're having pain and all this thing. But again, we need to continue the breastfeeding. Then we have to ask the mother to empty the breast manually. We have to teach her how we have to, she can manually express the breast milk. Then there should be frequent nursing or pumping of the breast milk, same. Then bed rest, fluids, analgesic can be given, and antibiotic will be given to the mother because this is an infection. Then we have to observe carefully for the signs of abscess formation. If it is not treated well, then it will again turn into the abscess. So 3% of mastitis cases, they develop into the abscess, and this is a severe one where the mother will need the incision and drainage. Antibiotics will be given to the mother for this. Analgesia and frequent emptying is required in this case. Again, if the abscess is there in one breast, the baby can be breastfed with the unaffected breast. So this was about the main breast problems. Again, if you're talking about the nipple problems, so here we again, why the nipple problems occur? Because the mother is not able to latch the baby properly. Again, I'll quote here about the Hemlata ma'am's session where she emphasized in her keynotes, like we need to focus on the latching, the tools. So we need to properly, being a midwife, we need to say to the mother ki how the latching should be there. You need to demonstrate ki how, what is the correct latching and how she can perform. So if there is proper latching, we can avoid many of the nipple and breast issues. So demonstrate the proper latching and positioning, cleanliness and attention to the fissures if there is any. Then there are various researches which have evidence, like applying the hind milk to the nipple after breastfeed, then exposure of the nipple to the air between the feet, hydrogel dressings, glycerin gel dressings, warm water compresses, mint tea bags, warm green tea bags. They all are effective. Peppermint water or the gel, olive oil, coconut oil, they all are effective in managing the cracked nipples and the issues with the nipple. So this was about the breast complications, how being a midwife we can manage. So we have discussed about the PPH, infections, thrombosis issues and breast complications. Here I'm quoting a study, a qualitative study where the interview was taken from the mothers, and a mother quoted, I felt desperate and felt like I was the only one with that kind of problem, because when I reached the hospital, I saw them wondering what it was, as it was a new kind of disease that I had, one that they had never seen before, and she was a case of fistula. So here we can see there are many complications that are not major one, but still they are the complications that are affecting the maternal life. So similarly, there are other complications that are endocrine disorders, postpartum thyroiditis, Sheehan syndrome, very rare. And again, as I said, the complications which can affect the quality of life, UTI, incontinence, hemorrhoids, constipations. So these are the non-life threatening, but still they create the problem. Again, now coming to the mental health of a postnatal mother, this should not be neglected. The postpartum psychological complications occur. Majority of the women, they face at least some of the postpartum blues. Then if they are not treated well, or if they persist, they can turn into the postpartum depression and the postpartum psychosis. If again the postpartum is not treated, it will turn into the postpartum psychosis. A study has been done where the nurse-led initiative has been taken, where they were doing the universal screening of the perinatal emotional complications. Whenever the mothers were coming for the follow-up, or when they were before discharge, it was compulsory that they should undergo the postnatal psychological assessment. So as madam has told, Edinburgh postnatal depression scale, other valid tools, depressions tool we can use to screen what is the psychological status of the mother. Then responsiveness of the mother, again this is very important. Other than the physical symptom, we have to see how is the response of the mother, whether she is responding to the baby, whether she is responding to the needs, her self needs and the baby's need and all this thing. Then what is her sleep patterns? Then weight loss or the weight gain, that can be assessed when she is at the home in that situations. Then assess for the fears of infant harm. This may also happen if she is developing the psychosis. So here what we have to watch for to identify whether she is having any kind of psychological problem, complications, we have to see low energy, fatigue level, sleep or appetite problems, persistent sad or anxious mood, irritability, low interest in or pleasure from the activities that used to be enjoyable. She has difficulty in carrying out the usual work. Like initially she won't be able to do, but at least after 2 weeks, 3 weeks, she can do the activities, but still in that she will find huge difficulties. Then she has the negative or hopeless feelings about herself or the newborns. Like you would have heard in your clinical areas when mothers are saying ki, I'm not able to take care of my baby, am I not a good mother in that way. Then multiple symptoms she may have, the like aches, pain, palpitations, numbness, and they are like without any physical cause. There are no physical cause for that, but still she's complaining there is something, some pain or palpitations is there. Then social withdrawal, she is not interacting with anyone. Poor hygiene, not maintaining hygiene of baby and herself. Then these are like postnatal blues. Then true postpartum depression is when a mother is depressed considerably with all the symptoms, and it persists for more than 2 weeks to disturb her routine activities. So all these things we have to see. Here comes the role of community healthcare workers, where they have to observe all these things when they are going for the visits, home visits. So these were about earlier they were the symptoms of blues and the depressions, but in psychosis there are some little bit different symptoms where she has insomnia, eating disorders, extreme anxiety or agitation. She may have the hallucinations, she may have the delusions, denying the birth, or like if there is any infant death. And all these psychological issues, they usually happen if there is any congenital anomaly in the newborn, or like there is IUD babies. In that case, those mothers are more prone to the these kind of issues. Then suicidal or homicidal thoughts, delirium, mania, she may have the bipolar disorders. So by this we can identify that yes, she is having some kind of psychological complications or issues. Now, how they all can be treated? Again, as I said, there are blues, there are depression and psychosis. It depends upon the severity of the symptoms. Sometimes it happens like if we are talking about the symptoms, if there is support from the family, the symptoms or the issue can be resolved. So again, it depends upon the severity. Counseling, individual counseling or like family counseling, we may ask the mother what are the reasons why you are having all this thing, or like we may communicate and we can come to know these are the reasons, because of this she is having some kind of problem issues in managing the situation. So in that way we can call the family members also, and we can have a counseling of the group. Then if there are severe symptoms, depression or psychosis, then pharmacological interventions are given, and support groups can also help. As the new evidences are there, support groups, they can help the new mothers to deal with these kind of psychological issues.
Excuse me,
Geeta? You're talking about...
Can
Yes, ma'am.
Wind up in next 2 to 3
Yes. I'll be, yes. Then it requires again psychosis and emergency situation where it requires the inpatient treatment. She has to be admitted in this case, and she has to be administered antipsychotic medications, and ECT may be given to the mother for the management. So summarizing about this topic, what ICM competencies a midwife should have to tackle the postnatal mother. Here they say we have to have the knowledge about the sign and symptom. Yes, these are the sign and symptom of PPH. These are the sign and symptom of this one. Perioral sepsis. So all these things we can just see yes, we have being a midwife, we should be knowledgeable about all these things, and we should have the skill of managing the situations and managing the at least giving the prompt actions we have to give, and at least we have to refer how we have to refer. All these competencies we should have. Okay, so this is a home. This is a message that you can take home. That is, let the vigilance go forward and give us victory in saving millions of mothers' life. As I said, we are neglecting the maternal postnatal phase. Like we say, yes, everything is okay. We have to be normal. Mother is also happy. Family members are also happy. But we have to be very vigilant. And this vigilance can prevent many of the postnatal complications and can save many of the lives. So coming to the reference part, these are some of the reference. You can just go to the WHO website where they have very clearly told about the management of the pregnancy, antenatal, intranatal and postnatal. These are pages from that previous this publications of WHO where they have clearly said what are the things you have to see and what intervention you can do. This is from same. These are some of the references. So thank you so much and giving me some extra minutes to extend the session. Thank you so much, ma'am.
Okay, congratulations, Geeta. It was an excellent session. You have presented the entire content extensively. And because of the shortage of time, I think we can take one question.
Yes.
Yeah. What is the onset of showing symptoms of postpartum psychosis? Maybe time of onset of postpartum psychosis.
Psychosis, like as I said, the all the psychological issues they generally develop after 2 3 days. First, it will not be like initially she has developed the psychosis. It will develop gradually from postpartum blues to the postpartum depression. If these cases are not handled, then she can have the psychosis. Or else, if she is having any kind of risk factor in the previous risk factor before the pregnancy or during the pregnancy, we can say ki yes, she may have the psychosis, but it does not develop immediately after delivery. It may develop after a few months. And we have seen the cases like after 9 months of delivery, after 1 year of delivery, the mothers are developing the psychosis. So it is late.
Yeah, it can vary.
I hope it is clear.
Yeah. Congrats, Geeta. It's a very
Thank
nice
you.
presentation. And you have a lot of positive feedback in the comment box. We can read after this.
Okay, thank you so
We'll
much.
conclude this session. I think we can move on to the next speaker.
Yes.
MSc she did in OBG and PhD nursing sciences. She has 14 years of clinical and teaching experience in various reputed institutions. If we talk of research, she published many papers in the national and international journals. Awards and achievement: Best Paper Award, first position in nursing informatics during National Conference on Building Next Generation Libraries and Information Services at Baba Fri University of Health Sciences, Faridkot, Punjab, India. Best Poster Award, first position in poster competition on AOGT Adolescent Health Subcommittee and Director of Family Welfare and Association of Obstetrical and Gynecological of Delhi. So, Aarti, you come forward with your contents and deliver.
Madam Aarti, you can share the screen. Madam, if you are not able to share the screen, please let us know. I will share your PPTs from here.
Dr. Aarti?
Madam, I will be sharing her slides in a few moments. Please give us time.
Unmute कर. Am I audible?
Yes, ma'am, we can hear you.
Put the PPT of or shares, Madam shares.
Ma'am, from our side, we will be doing, and then Aarti will speak. Just people need 2-3 minutes.
No, if you put it now, because it's okay, but there was some problem in this, so you put up the resume of Aarti.
Yes, ma'am, there is a problem from our side. We are sharing her screen. Please, another 1 minute we will take, ma'am. Sorry for the interruption.
No problem. I can't see the PPT over here. Okay, problem.
Ma'am, please put the presentation mode. Fine, ma'am, your screen is visible.
Yes, now.
Madam Aarti, we are not able to hear you. You are not audible to us, ma'am.
Yes, to me also it's not audible at all.
Ma'am, please unmute yourself. To all the speakers and the chairpersons, sorry for the inconvenience. Within a minute or half of minute, we will start the presentation. There is some technical problem we are facing from our side.
Okay.
Thank you for being patient.
PPT.
Survey, it is 47.8%, and total unmet needs 12.9%, unmet needs spacing it is 5.7, and unmet needs limiting it is 7.2. So here we can see usage of this condom it is 5.6%, and pills 4.1%, IUCD, PPIUCD it is approximately 1.5, male sterilization it is really very less 0.3%, female sterilization it is 3.6. So every year, approximately 2 lakh million women become pregnant in developing countries, and more than 5 lakh of them die of pregnancy-related causes, and millions suffer a significant complication of pregnancy. Additionally, 7 million perinatal deaths occur as a result of maternal health problems. So this is the data as per WHO. Why family planning? Why it is very much important? So it prevents 1 in every 3 maternal deaths. So with the help of family planning, we can prevent the maternal death, prevent unintended pregnancies and unsafe abortion, prevent high-risk pregnancies, 3 times more risk of child mortality if the interval is less than 18 months. It prevents infant death. For every woman who dies of pregnancy and childbirth complication, at least 20 more suffer long-term illness. Contraceptive basket of choice under National Family Planning Program. So temporary, there are temporary methods as well as permanent methods. Temporary methods, condom, Nirod, oral contraceptive pills, combined oral contraceptives, Mala and Chaya, emergency contraceptive pills, E-pill, then IUCD 380, 375 or injectable. Permanent methods, male sterilization, conventional vasectomy, female sterilization, that is mini lap or laparoscopy. So this is the expansion of the basket of family planning choices. For example, introduction of new contraceptive choices like injectable. Under injectable contraceptive, Antara program is there. In this 3 months, once they have to take injection. Next Chaya, then progesterone only pill. Next introduction of new devices like IUCD 375. It is very effective, and it is 5 years. It is effective for 5 years. Introduction of new method like postpartum IUCD was introduced in the program in 2010-11, has provided postpartum women an effective spacing option. So augmentation the demand through ASHA scheme for family planning. Home deliveries of contraceptives. So this is also under a new scheme, new choices. So ensure spacing at birth. Next, pregnancy testing kits. This is also available. At ASHA level, pregnancy testing kits are now a part of ASHA kit so as to ensure early management of pregnancy. Promoting quality sterilization services, promoting quality IUCD service, interval IUCD can be provided in all public health facilities by a trained provider in PPIUCD postpartum intrauterine device inserted within 48 hours after delivery in facilitate conducting deliveries. PA-IUCD post-abortion IUCD inserted within 12 days of abortion in PSC and above facilities. Next, PP-IUCD and PA-IUCD incentive scheme. So this is also very motivating for them. Trained skills providers inserting PP-IUCD, PA-IUCD rupees 150 per insertion. ASHA pumping client 150 insertion per insertion. Beneficiary also will get rupees 300. So this is the PP-IUCD acceptance out of total public health delivery. So here we can see in Mizoram 1.2% only, and Tamil Nadu it is highest 40.2. So on an average in India it is 16.3%. New initiatives under family planning. So Mission Parivar Vikas, a unified software for family planning logistics, expansion of contraceptive basket of choices, new contraceptive packing, new family planning media campaign. Under Mission Parivar Vikas to accelerate access to high quality family planning choices based on information, reliable service and supply within the right framework. So these all come under this Mission Parivar Vikas, like delivering assured services, deviating with new promotional scheme, ensuring security, then building capacity, service provider, creating enabling environment, close monitoring and evolving implementation. Next one is unified software for family planning logistics. So here instant access to stock information from the national level to Asha level. So on the ground level, they are providing the services, auto forecasting of contraceptives, web-based, app-based or SMS-based applications. SMS alert for key indicators, auto-generated report for program review. Or a new communication campaign under it, family planning web pages, toll-free helpline number, outdoor campaign or a 52-week long radio chat show, print ad posters available, the celebrity WhatsApp videos or television ads. So this all help to enhance or motivate the people. Next one is the breastfeeding. So breastfeeding, already we all know about this breastfeeding. It is really very important. So here we can see approximately 64.6% adequate breast milk secretion, or 12.4% bottle feed is more nutritious. As the people think like bottle feed is more nutritious than the breast milk, or 11.5% they think like unable to breastfeed, or poor weight gain approximately 7.4, or some other reason like mother, she is not present, she's doing some studies or travel or job joining. So these all are the some other reasons. Exclusive breastfeeding is the safe, sound, and sustainable way to feed an infant for the first 6 months of life. But breastfeeding is important for more than 6 months. World Health Organization and United Nations Child Emergency Fund recommend that breastfeeding should continue with appropriate complementary food up to 2 years or beyond. Babies grow and well best when they are fed in this way. So breastfeeding should be complementary, should be continuously with the weaning, and it should be up to the 2 years of age. So exclusive breastfeeding means that the infant receive only breast milk from his or her mother or a wet nurse, or expressed milk, breast milk, or no other food or drinks. Already we know about the exclusive breastfeeding. Next, this is the new concept, golden bow. So golden bow, it is a symbol for gold standard, that is ideal, exclusive, continued breastfeeding. The golden bow is a joint outreach initiative of United Nations Children Emergency Fund and World Alliance for the Breastfeeding Action. So here we can see 2 loops are there. 2 loops means upper loop it represents the baby and lower loop represents the mother, and the node it represents father, family and community, which help in breastfeeding. So it protecting, promoting and supporting for the breastfeeding. Changing in the composition of breast milk. So in the first week of pregnancy, alveoli is swollen with colostrum, a thick yellowish substance that is high in protein and contain less fat and glucose. So glucose than the mature breast milk. So composition of cow's milk as a cause of iron deficiency in infant and toddler. So we can say like breast milk is the best and ideal food for the babies. This is the composition of human colostrum, mature breast milk, cow's milk. Exclusive breastfeeding in special situation. Exclusive breastfeeding and HIV. So 10 to 20% of infant of HIV positive mother may become infected through breastfeeding. However, if the woman choose not to breastfeed, their infant run all the risk of artificial feeding, which are particularly serious when the safe preparation of artificial feeding is difficult. So if the level of infection disease is high, then the mother can think Or here, like if the mother on the regular follow, then the chances of the HIV positive in baby it is very less. So approximately 100% result HIV negative. Even the baby is on the mother's feed, breast milk. Low birth weight babies grow well and are healthier when they are fed breast milk exclusively. Only form of nutritional support may be needed in the early days before the baby's condition is stable. Supplements such as calcium, phosphorus, if needed, can be given with breast milk. So for the premature babies who are 8 weeks premature can start sucking at the breast. Who are 4 weeks premature can feed themselves at the breast. Or feeds may need to be more frequent and take longer than with larger babies. If an infant cannot take all its feeds from the breast, the mother can express breast milk and cup feed. Mothers who have learned how to express and cup feed are often very good at the teaching and the helping others. Next one is the baby-friendly hospital initiatives. Since 1993, WHO effort to improve health, infant and young children nutrition have focused on promoting breastfeeding. Baby-friendly hospital is a scheme is based that advocate immediate breastfeeding of the children born in the hospital. Mother are initiative breastfeeding within an hour. So within half an hour, usually we start the breastfeeding. As soon as the baby birth, we just put the baby on the mother's breast. So it helps in many ways. So objectives to establish the breastfeeding in order to protect newborn healthy by becoming baby healthy, to boost breastfeeding and to counter the worldwide trend towards bottle feeding, to fulfill the initiative UNICEF and WHO laid down 10 steps to create the baby friendly environment. So these are the steps which we are following under this baby friendly initiatives. Have a written breastfeeding policy that is routinely communicated to all the staff, trained healthcare staff in skill necessary to implement this policy. Step 3, inform all pregnant women about the benefit and management of breastfeeding. Help mother initiate breastfeeding within half an hour of birth, and show mother how to breastfeed, how to maintain lactation, even they are separated from their infants. Next, step 6, give newborn infant no food or drink other than breast milk unless medically indicated. Step 7, practice rooming in, allow mothers and infant to remain together round the clock. Step 8, encourage breastfeeding on demand. Step 9, give no artificial feeds or pacifiers to the breastfeeding babies. Foster the establishment of the breastfeeding. So these all are the steps which cover the whole area for the successful breastfeeding. So here, conclusion, human milk, as we know and we have like discussed, human milk is the ideal nourishment of infant survival, growth and development. Exclusive breastfeeding means starting breastfeeding as early as possible. Breastfeeding also known as nursing in the feeding of baby and young children with milk from the woman's breast. So this is all about the breastfeeding and family planning counseling. Thank you all for patience hearing.
Yeah. Congrats, Dr. Ardi. We have made, even though we had technical difficulties, you have made it up, and it was an extensive presentation covering the recent updates. Congratulations. Ma'am Rajrani. Ma'am, you have to unmute yourself.
Yes. Yes, Aarti, you have discussed it in a, with the data of the family planning, contraceptive and types, and it is useful one and it's very, very important, you know, for the planning of a family. So I am very grateful to the, you know, Principal of College of Nursing, AIMS Jodhpur, that he has organized a wonderful this conference, and I am also the part of it. I am very happy and thankful to all the staff for this.
Okay, thank you so much, ma'am.
Thank you so much, Professor Rajrani ma'am and Dr. Lekha Vishwanath ma'am, for holding this session along with the eminent speakers. Now, I would like to request our participants to take a break for sumptuous lunch and let us all join back sharp at 2 p.m.